Aujourd'hui ça fait 6 ans que nous sommes mariés. Tu m'as donné de beaux enfants, tu sais. Depuis ce petit bal où l'on s'est rencontrés, je n'ai pas cessé de t'aimer. Mais ce soir j'ai envie de déposer mon tablier, de me faire belle pour toi comme par le passé. Ton fauteuil, ton journal, tes cigarettes et la télé, ce soir laisse-les de côté. Emmène-moi danser ce soir, joue contre joue et serré dans le noir, et fais-moi la cour comme aux premiers instants, comme cette nuit où tu as pris mes 17 ans. Emmène-moi danser ce soir, flirtons ensemble enlacés dans le noir. Timidement, dis-moi Michel, je t'aime. Amoureusement, je suis restée la même. Il n'y a plus que tes amis et le football qui comptent pour toi. Et j'ai l'impression que tu ne vois plus en moi que la mère de tes enfants. Oh, je ne te demande pas de m'offrir des fleurs tous les jours, mais de faire de temps en temps un geste d'amour. Et ce soir, je voudrais encore une fois te retrouver, rentrer au petit jour et puis t'embrasser. Ton fauteuil, ton journal, tes cigarettes et la télé, ce soir laisse-les de côté. Emmène-moi danser ce soir, joue contre joue et serré dans le noir, et fais-moi la cour comme aux premiers instants, comme cette nuit où tu as pris mes 17 ans. Emmène-moi danser ce soir, flirtons ensemble enlacés dans le noir. Timidement, dis-moi Michel, je t'aime. Amoureusement, je suis restée la même. Emmène-moi danser ce soir, joue contre joue. Tu viens comme dans un rêve et tu t'endors tout contre moi, comme le jour qui se lève dans mon cœur quand j'ai un peu froid. Tu souris et rien n'est plus tendre alors que le vent et la pluie qui glisse sur ton corps. Oh, oh, si la nuit te fait peur, seul tout au fond de ton cœur, si tu cherches une amie, pense à moi. Je ne serai jamais loin de toi. Et même si c'est toutes les nuits, si je dois passer ma vie à te consoler, je serai là. Je ne serai jamais, jamais loin de toi. Tu vis comme dans mon rêve, tu te réveilles tout contre moi. Chaque jour qui se lève me fait douter, mais tu es là à jamais, dans mes joies, dans mes désirs, pour toujours. Je voudrais caresser ton sourire, et même si
tu cries, si tu pleures, même si les hommes te font peur, si leur folie t'enchaîne les bras, je ne serai jamais loin de toi. Et même si demain tu m'oublies, si tu rêves d'une autre vie, tu peux partir là où tu voudras, je ne serai jamais, jamais loin de toi. Si la nuit te fait peur, c'est tout au fond de ton cœur. Si tu cherches une amie, pense à moi, je ne serai jamais loin de toi. Et même si demain tu m'oublies, si tu rêves d'une autre vie, tu peux partir là où tu voudras, je ne serai jamais, jamais, jamais loin de toi. Non, 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 non. Là où tu voudras, jamais, jamais loin de toi. Non, 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 non. Tu peux partir là où tu voudras, je ne serai jamais, jamais loin de toi.
Step up the tour bus, nobody knows us. Get in the car like skip, staying up all night, order me pad thai, then we gon' sleep till noon. Me with no makeup, you in the bathtub, bubbles and bubbly. Ooh, this is a pleasure, feel like we never like this regular. Quick, 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 and post, drip, drip, dripped, and gold. Quick, 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 let's go. Kiss me and take off your clothes. Imagine a world like that. Imagine a world like that. We go like up till I'm asleep on your chest. Love how my face fits so good in your neck. Why can't you imagine a world like that? Imagine a world. Knew you were perfect after the first kiss. Took a deep breath like, ooh, feels like forever. Baby, I never thought that it would be you. Tell me your secrets, all of the creep shit, that's how I know it's true. Baby, direct it, name in the credits, like the movies do. Quick, 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 and post, drip, drip, dripped, and gold. Quick, 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 let's go. Kiss me and take off your clothes. Imagine a world like that. Imagine a world like that. We go like up till I'm asleep on your chest. Love how my face fits so good in your neck. Why can't you imagine a world like that? Imagine a world. Can you imagine it? Can you imagine it? Can you imagine it? Can you imagine it? Can you imagine it?
tierra bella, de mi tierra santa. Oigo ese grito de los tambores y los timbales al cumbanchá. Y ese pregón que canta un hermano que de su tierra vive lejano y que recuerdo le hace llorar. Una canción que vive entonando de su dolor, de su propio llanto y se le escucha penar. La tierra te duele, la tierra te da en medio del alma cuando tú no estás. La tierra te empuja de raíz y cal. La tierra suspira si no te ve más. La tierra donde naciste no la puedes olvidar porque tiene tus raíces y lo que dejas atrás. La tierra te duele, la tierra te da en medio del alma cuando tú no estás. Siguen los pregones, la melancolía y cada noche junto a la luna sigue el guajiro entonando el son. Y cada calle que va a mi pueblo tiene un quejido, tiene un lamento, tiene nostalgia como su voz. Esa canción que sigue entonando corre la sangre y sigue llegando con más fuerza al corazón. La tierra te duele, la tierra te da en medio del alma cuando tú no estás. La tierra te empuja de raíz y cal. La tierra suspira si no te ve más. Tiene un quejido, tiene un lamento, nunca lo olvido. La llevo en mis sentimientos, sí señor, oigo ese grito. Vive el recuerdo, corre en mi sangre. La llevo por dentro como no, canto de mi tierra bella y santa. Sufro ese dolor que hay en su alma, aunque esté lejos yo la siento. Y un día regreso, yo lo sé. Siguen los pregones, la melancolía. Cada noche junto a la luna sigue el guajiro entonando el son. Cada calle que va a mi pueblo tiene un quejido, tiene un lamento. La nostalgia de su voz me llega con fuerza al corazón. La tierra te duele, la tierra te da en medio del alma cuando tú no estás. La tierra te empuja de raíz y cal. La tierra suspira si no te ve más.
Will you hold the line when every one of them is giving up and giving in? Tell me, in this house of mine, nothing ever comes without a consequence or cost. Tell me, will the stars align? Will heaven step in? Will it save us from our sin? Will it? 'Cause this house of mine stands strong. That's the price you pay. Leave behind your heart and cast away. Just another product of today. Rather be somebody. Let me see the light within the dark trees shadowing what's happening. Looking through the glass, find the wrong within the past, knowing we are the youth. Caught until it bleeds out a world without the peace, face a bit of the truth. The truth. That's the price you pay. Leave behind your heart and cast away. Just another product of today. Rather be the hunter than the prey. And you're standing on the edge, face up, 'cause you're a natural. I'm beating hard as stone. You gotta be so cold to make it this world. Yeah, you're a natural. Living your life control. You gotta be so cold. Yeah, you're a natural. Deep inside me, I'm fading to black, I'm fading. Took an oath by the blood in my head, won't break it. I can taste it. The end is upon us, I swear. I'm gonna make it. I'm gonna make it. I'm beating hard as stone. You gotta be so cold to make it this world. Yeah, you're a natural. Living your life control. You gotta be so cold. Yeah, you're a natural. Yeah, you're a natural.
I don't wanna be broke when I DIE. Wanna be living it up in VIP. Tryna get in the club, they wanna CID. Want me to wear nice shoes and a TIE. I've been working and getting by, but that ain't enough to satisfy. 'Cause I got dreams for you and I, so I got money on my mind. So if you wanna stack it up, man, you gotta work for it. Ain't nobody gonna be doing it for you. I got dreams and I got time, but that ain't enough to get me by. So I'll stack it up, man, I gotta work for it. Yeah, I got money on my mind. I got money on my mind. I wanna flex hard like DOE, but right now my car need the MOT. And I can't give the vet no TIP, but like him I got dreams and they B.I.G. Tried to be a better guy, but they weren't enough to satisfy. I got dreams for you and I got money on my mind. So if you wanna stack it up, man, you gotta work for it. Ain't nobody gonna be doing it for you. I got dreams and I got time, but that ain't enough to get me by. So I'll stack it up, man, I gotta work for it. Yeah, I got money on my mind. I got money on my mind.
I know shit don't come free, you gotta work for it. Lamborghini Urus bought it when I first saw it. She called me creepin', I had to buy her a purse for it. I think if I ain't have money, I'd be the worst for it. And if I ain't have money, I would've been lost her. The loudest ones was the brokers, I was a shit talker. The loudest ones was the brokers, and I was struggling. Girls call me friend, now they owe me that money coming in. Ain't the wrong fiend, I put it in Louis luggages. Took a sister lean, bought her a couple luggages. Wasn't always sweet, Capri Suns for 50 cents. Now I just hate to reminisce.
If you wanna stack it up, man, you gotta work for it. Ain't nobody gonna be doing it for you. I got dreams and I got time, but that ain't enough to get me by. So I'll stack it up, man, I gotta work for it. Yeah, I got money on my mind. I got money on my mind. I got money on my mind.
si tu n'existais pas, dis-moi pourquoi j'existerais. Pour traîner dans un monde sans toi, sans espoir et sans regret. Et si tu n'existais pas, j'essaierais d'inventer l'amour, comme un peintre qui voit sous ses doigts naître les couleurs du jour et qui n'en revient pas. Et si tu n'existais pas, dis-moi pour qui j'existerais. Des passants endormis dans mes bras que je n'aimerais jamais. Et si tu n'existais pas, je ne serais qu'un point de plus dans ce monde qui vient et qui va. Je me sentirais perdu. J'aurais besoin de toi. Et si tu n'existais pas, dis-moi comment j'existerais. Je pourrais faire semblant d'être moi, mais je ne serais pas vrai. Et si tu n'existais pas, je crois que je l'aurais trouvé. Le secret de la vie, le pourquoi, simplement pour te créer et pour te regarder. Et si tu n'existais pas, dis-moi pourquoi j'existerais. Pour traîner dans un monde sans toi, sans espoir et sans regret. Et si tu n'existais pas, je sais. Les matins se suivent et se ressemblent. Quand l'amour fait place au quotidien, on n'était pas fait pour vivre ensemble. Ça ne suffit pas toujours de s'aimer bien. C'est drôle, hier on s'ennuyait, et c'est à peine si l'on trouvait des mots pour se parler du mauvais temps. Et maintenant qu'il faut partir, on a 100 000 choses à dire qui tiennent trop à cœur pour si peu de temps. On s'est aimé comme on se quitte, tout simplement sans penser à demain. À demain qui vient toujours un peu trop vite, aux adieux qui quelquefois se passent un peu trop bien. On fait ce qu'il faut, on tient nos rôles, on se regarde, on rit, on craint un peu. On a toujours oublié quelque chose. C'est pas facile de se dire adieu. Et l'on sait trop bien que tôt ou tard, demain peut-être ou même ce soir, on va se dire que tout n'est pas perdu. De ce roman, il ne inachevé. On va se faire un conte de fées, mais on a passé l'âge, on n'y croirait plus. On s'est aimé comme on se quitte, tout simplement sans penser à demain. À demain qui vient toujours un peu trop vite. Aux adieux qui quelquefois se passent un peu trop bien. Roméo, Juliette et tous les autres, au fond de vos bouquins, dans mes empais, une simple histoire comme la nôtre, et de celle qu'on n'écrira jamais. Allons petite, il faut partir, laisser ici nos souvenirs. On va descendre ensemble si tu veux. Et quand elle va nous voir passer, la patronne du café va encore nous dire salut les amoureux. On s'est aimé comme on se quitte, tout simplement sans penser à demain. À demain qui vient toujours un peu trop vite. Aux adieux qui quelquefois se passent un peu trop bien.
Si tu ne me revenais pas, bien sûr je poursuivrai ma route. Je connais la peur et le doute, mais où me mènerait mes pas. Si tu ne me revenais pas, et j'aurais attendu pourquoi tout ce temps que tu me reviennes, ces jours qui furent des semaines, ces semaines qui furent des mois. Si tu ne me revenais pas, comment faut-il te l'expliquer? Je t'aime et je le crie en monde entier. Je t'aime. Si tu ne me revenais pas, bien sûr j'irai coûte que coûte. J'ai suivi tant et tant de routes, commis tant et tant de faux pas, que tout peut arriver sans toi. N'importe qui, n'importe quoi, qui n'a jamais terni sa route, me jette la pierre du doute, me jette le premier pourquoi. Tu vois, je m'égare déjà. Comment faut-il te le crier? Je t'aime et je me fous du monde entier. Je t'aime. Si tu ne me revenais pas, bien sûr je poursuivrai ma route. Je connais la peur et le doute, mais où me mènerait mes pas? Si tu ne me revenais pas.
plage. Il faut alors s'en aller, les vacances sont durées, emportant la tendresse de nos baisers.
Quand tu reviendras, on sera si bien chez nous. Quand tu reviendras, et la vigne aura couvert les murs que tu n'aimais pas. Il n'y aura plus de courant d'air, j'aurai réparé le toit. Tu trouveras notre chambre aussi douce qu'un printemps, car de janvier à décembre, il y a le soleil qui t'y attend. Et s'il pleut ce jour-là, il fera ciel bleu chez nous. Tu ne tousseras plus aux larmes à cause du feu de bois. La cheminée tire comme un charme, je l'ai ramené pour toi. Quand tu reviendras, on sera si bien chez nous. Mieux que n'importe où. J'ai bien changé, tu sais. Je n'écris plus n'importe quoi. Tu verras qu'en moins d'un an, je n'ai pas perdu mon temps. Je t'ai fait de mes 10 doigts un chaînon digne de toi. Je me souviens de ta peau, de la douceur que je lui dois. J'ai vendu mon vieux piano pour t'acheter des draps de soie. Dépêche-toi, le temps passe, reviens-moi tant que j'y crois. Chaque chose est à sa place, il ne manque plus que toi. Et la vigne aura couvert les murs que tu n'aimais pas. Il n'y aura plus de courant d'air, j'aurai réparé le toit. Tu trouveras notre chambre aussi douce qu'un printemps, car de janvier à décembre, il y a le soleil qui t'y attend.
Elle a la peau couleur du soleil, elle a le secret des abeilles, elle sais comme on fait les enfants. Elle, c'est un avion blanc dans le ciel. Elle a déjà brûlé ses ailes. Elle est née dans un ouragan. Elle, je l'ai croquée comme une pomme. Elle n'en veut parler à personne. Elle a les yeux de l'océan. Elle, moitié Venise et moitié Rome. Elle a déjà aimé des hommes. Elle a le cœur comme un diamant. Elle, c'est un loup, une tourterelle. C'est un animal étonnant. Elle, moitié velours, moitié dentelle. Toujours cruelle et cependant, c'est une lady, elle. C'est une femme tout simplement. Elle, je connais ses châteaux de paille. Elle a grandi à la campagne. Elle a le sourire de ses gens. Elle, dans toutes les soirées de la ville, elle a le feeling et le style. Elle fait tout ça naturellement. Elle, c'est un loup, une tourterelle. C'est un animal étonnant. Elle, moitié velours, moitié dentelle. Toujours cruelle et cependant, c'est une lady, elle. C'est une femme tout simplement. Elle a la peau couleur du soleil. Elle a des larmes au goût de miel. Elle pleure comme pleurent les enfants. Elle, c'est le plus violent des poèmes. Elle n'a pas peur de dire je t'aime. Elle fait l'amour exclusivement. Elle, c'est un loup, une tourterelle. C'est un animal étonnant. Elle, moitié velours, moitié dentelle. Toujours cruelle et cependant, c'est une lady, elle.
enfant nu sur les galets. Le vent dans tes cheveux défaits. Comme un printemps sur mon trajet. Un diamant tombé d'un coffret. Seule la lumière pourrait défaire nos repères secrets. Où mes doigts pris sur tes poignets. Je t'aimais, je t'aimais, je t'aimerais. Je t'aimerais. Et quoi que tu fasses, l'amour est partout où tu regardes. Dans les moindres recoins de l'espace. Dans les moindres rêves où tu t'attardes. L'amour comme s'il en pleuvait. Comme s'il en pleuvait. Nu sur les galets. Le ciel prétend qu'il te connaît. Il est si beau, c'est sûrement vrai. Lui qui ne s'approche jamais. Je l'ai vu pris dans tes filets. Le monde a tellement de regrets. Tellement de choses que l'on promet. Une seule pour laquelle je suis faite. Je t'aimais, je t'aimais, je t'aimerais. Je t'aimerais. Et quoi que tu fasses, l'amour est partout où tu regardes. Dans les moindres recoins de l'espace. Dans les moindres rêves où tu t'attardes. L'amour comme s'il en pleuvait. Comme s'il en pleuvait. Nu sur les galets. On s'envolera du même quai. Les yeux dans les mêmes reflets. Pour cette vie et celle d'après. Tu seras mon unique projet. Je m'en irai poser tes portraits. À tous les plafonds de tous les palais. Sur tous les murs que je trouverai. Et juste en dessous j'écrirai que seule la lumière pourrait et mes doigts pris sur tes poignets. Je t'aimais, je t'aimais, je t'aimerais. Et quoi que tu fasses, l'amour est partout où tu regardes. Dans les moindres recoins de l'espace. Dans les moindres rêves où tu t'attardes. L'amour comme s'il en pleuvait. Comme s'il en pleuvait. Nu sur les galets. Et quoi que tu fasses, l'amour est partout où tu regardes. Dans le moindre recoin de l'espace. Dans les moindres rêves où tu t'attardes. L'amour comme sur les galets.
Senti les voix sous ta main, doudou m'envie. Et puis des bras enveloppés moi, doudou m'envie. L'oxygène qui m'a besoin pour respirer. Sur pas moi à tout moment, manquer de tomber. Ou pas besoin qui m'a mandé, doudou m'envie. Pas tellement si plié, doudou m'envie. Pas ni rien dans l'univers, mais y'a qui ça. Qui s'y revient là sous la terre, plus douce qui ça. J'aime ça. Un seul Thibaut, il peut sauver l'humanité. Et des Thibauts, ça peut durer l'éternité. C'est Henri Mac qui peut gérer toute maladie. Ça qui panie au pérégris pour toute la vie. Rêvez-vous chaud à ce qu'un moins de m'envie. Et puis les voix sous ton moins de m'envie. Pour l'oxygène qui m'a besoin pour respirer. C'est vitamine au cabas moins pour moi tien c'est magie, c'est plaisir, poésie, c'est chalet, c'est la ligne qu'éclaire moi. C'est vertige, c'est frisson, la passion, affection, c'est l'amour caché et moi. C'est soleil dans la vie moi. J'aime ça. Pas jamais ni assez. Tout de bon moi. Bisous, bisous, bisous.
panties and bottles of bubbles. Girls with tattoos who like getting in trouble. Lashes and diamonds, ATM machines. Buy myself all of my favorite things. Been through some bad shit, I should be a savage. Who would've thought it turned me to a savage? Rather be tied up with calls and not strings. Write my own checks like I write what I sing. Yeah. My wrist, stop watching. My neck is fuzzy. Make big deposits. My gloss is popping. You like my hair? Gee, thanks. Just bought it. I see it. I like it. I want it. I got it. Yeah. I want it. I got it. 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 Yeah. You like my hair? Gee, thanks. Just bought it. I see it. I like it. I want it. I got it. Yeah. Wearing a ring, but ain't gon' be no misses. But matching diamonds for 6 of my bitches. I'd rather spoil all my friends with my riches. Think retail therapy, my new addiction. Whoever said money can't solve your problems must not have had enough money to solve them. They say which one, I say nah, I want all of them. Happiness is the same price as red bottoms. My smile is beaming, my skin is gleaming. The way it shine, I know you seen it. I bought a crib just for the closet, both his and hers. I want it, I got it. 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 You like my hair? Gee, thanks. Just bought it. I see it, I like it. I want it, I got it. My receipts be looking like phone numbers. If it ain't money, then wrong number. Black card is my business card. The way it be setting the tone for me. I don't need a brag, but I be like, put it in the bag, yeah. When you see the max, they stacked up like my ass, yeah. Go from the south to the booth, make it all back in one loop. Give me the loot, never mind, I got the juice. Nothing but never we shoot. Look at my neck, look at my neck. Ain't got enough money to pay me respect. Ain't no budget when I'm on the set. If I like it, then that's what I get, yeah. I want it, I got it. 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 You like my hair? Gee, thanks. Just bought it. I see it, I like it. I want it, I got it. Yeah.
Yeah, you got that yummy, that yummy, that yummy, yummy. Yeah, you got that yummy, that yummy, that yummy, yummy. Say the word on my way. Yeah, babe, yeah, babe, yeah, babe. Any night, any day. Say the word on my way. Yeah, babe, yeah, babe, yeah, babe. In the morning or late. Say the word on my way. Bonafide stallion. Ain't no stable, no, you stay on the run. Ain't on the side, you're number one. Yeah, every time I come around, you get it done. 50-50, love the way you split it. 100 racks on me, spin it, babe. Light a match, get lit, babe. That jet set, watch the sunset, kinda. Yeah, yeah. Rolling eyes back in my head, make my toes curl, yeah, yeah. Yeah, you got that yummy, that yummy, that yummy, yummy. Yeah, you got that yummy, that yummy, that yummy, yummy. Say the word on my way. Yeah, babe, yeah, babe, yeah, babe. Any night, any day. Say the word on my way. Yeah, babe, yeah, babe, yeah, babe. In the morning or late. Say the word on my way. Standing up, keep me on the rise. Lost control of myself, I'm compromised. You're incriminating. No disguise, and you ain't never running low on supplies. 50-50, love the way you split it. 100 racks on me, spin it, babe. Light a match, get lit, babe. That jet set, watch the sunset, kinda. Yeah, yeah. Rolling eyes back
back in my head, make my toes curl, yeah, yeah. Yeah, you got that yummy, that yummy, that yummy, yum. You stay flexing on me. Yeah, you got that yummy, that yummy, that yummy, yum. Say the word on my way. Yeah, babe, yeah, babe, yeah, babe, yeah, babe. Any night. Say the word on my way. Yeah, babe, yeah, babe, yeah, babe, yeah, babe. In the morning or late. Say the word on my way. Hop in a Lambo, I'm on my way. True house slippers on with a smile on my face. I'm elated that you are my lady. You got the yum, 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 yum. You got the yum, yum, yum. Whoa. Whoa. Yeah, you got that yummy, that yummy, that yummy, yummy. Yeah, you got that yummy, that yummy, that yummy, yum. Say the word on my way. Yeah, babe, yeah, babe, yeah, babe, yeah, babe. Any night. Say the word on my way. Yeah, babe, yeah, babe, yeah, babe, yeah, babe. In the morning or late. Say the word on my way.
My mom was forced to just get us out of a situation that wasn't the safest. Education is really important to me, and it is for my mom.
I didn't know how to ask for help. I just want other people to have a place where they can go to and talk to each other.
We are on the edge of Skid Row, where poetry met me back in 2000. I'm here now, because this fear now, I say to myself, is real now. So let's deal now.
Picture perfect, you don't need no filter. Gorgeous, make them drop dead, you a killer. Shower you with all my attention. Yeah, these are my only intentions. Stay in the kitchen cooking up, got your own bread.
Good morning to you, everyone.
Make sure that you don't need no mentions. Yeah, these are my only intentions. Shout out to your mom and dad for making you. Standing ovation, they did a great job raising you. When I create, you're my muse. The kind of smile that makes the news. Can't nobody throw shade on your name in these streets. Triple threat, you a boss, you a bank, you a beast. You make it easy to choose. You got a mean touch, I can't refuse. No, I can't refuse it. Picture.
Since no one is dancing for this good music, I'm only going to tell you guys to only give you a good morning. How are you? Yes, I'm called Grace Kansaisa. I'm an orthopedic surgeon, and I will be the moderator for this session. I hope you're all excited to be here this morning. So we are grateful to have the first Rwandan Surgical Research Open Day. Yay! If we start begging to have a clap, what will happen at 5? So we apologize for the delays. We are waiting for the guest speaker to arrive, and she'll be here with us in 10 minutes. So we'd like to just a small wrap up to invite everyone. You are all welcome to attend this session. We are starting at 9. And so for that purpose, since we'll be 1 hour late, we wish to have all presenters to have their slides shared to the IT team so that we start on time and so that we don't delay any further. So you are welcome, make yourselves comfortable, and in 10 minutes will be all yours. Thank you very much.
God will make a way where there seems to be no way. He works in ways we cannot see. He will make a way for me. He will be my guide, hold me closely to his side. With love and strength for each new day, he will make a way. He will make a way. Oh, God will make a way where there seems to be no way. He works in ways we cannot see. He will make a way for me. He will be my guide, hold me closely to his side. With love and strength for each new day, he will make a way. He will make a way. By a roadway in the wilderness, he'll lead me. Rivers in the desert will I see. Heaven and earth will fade, but his word will still remain, and he will do something new today. Oh, God will make a way where there seems to be no way. He works in ways we cannot see. He will make a way for me. He will be my guide, hold me closely to his side. With love and strength for each new day, he will make a way. He will make a way. With love and strength for each new day, he will make a way. He will make a way. Yes, he will. He will make a way for you. just want to be where you are, dwelling daily in your presence. I don't want to worship from afar. Draw me near to where you are, and I just want to be where you are, in your dwelling place forever. Take me to the place where you are, 'cause I just want to be with you. I want to be where you are, dwelling in your presence, feasting at your table, and surrounded by your glory. In your presence, that's where I always want to be. I just want to be. I just want to be with you, and I just want to be where you are, dwelling daily in your presence. I don't want to worship from afar. Draw me near to where you are. Strength and my song, and when I'm in your presence, though I'm weak, you're always strong. Yes, you are. I just want to be where you are, in your dwelling place forever. Take me to the place where you are, I just want to be, I just want to be with you. Make it your prayer. I just want to be, I just want to be with you. Tempest, only you can still. My soul is thirsty, Lord, to know you as I know. Drink from the river that flows before your throne. Take me deeper, deeper in love with you. Jesus, hold me close in your embrace. Take me deeper, deeper than I've ever been before. Well, I just want to love you more and more. How I long to be deeper in love. Sunrise to sunrise, I will seek your face. Drawn by the Spirit to the promise of your grace. My heart has found in you a hope that will abide. Jesus, hold me close in your embrace.
You are not meaningless. You are very meaningful to us. Why are you sitting behind?
Oh yes.
Leave the back seat for the latecomers. So please, the one who are seated on the backbenchers. Hello, backbenchers. We are seeing you. Venuste, Guido.
Love you more and more. How I long to be deeper in love. Oh yes, how I long to be deeper in love. Oh yes. Hear our prayer. We are your children, and we've gathered here today. We've gathered here to pray. Hear our cry. Oh Lord, we need your mercy, and we need your grace today. Hear us as we pray. Our Father, who art in heaven, hallowed be thy name. Our Father, hear us from heaven. Forgive our sins, we pray. Our song as it rises to heaven. May your glory fill the earth as the waters cover we've gathered here to pray. Hear our cry. Oh Lord, we need your mercy and we need your grace today. Yes, we do. Hear us as we pray. Sing it, our Father. Our Father, who art in heaven, hallowed be thy name. Our Father, hear us from heaven, forgive our sins, we pray. Our Father, our Father, who art in heaven, hallowed be thy name. Our Father, hear us from heaven, forgive our sins, we pray. Forgive our sins, we pray. Forgive our sins, we pray. Oh yes. For all you've done, for all you're going to do, we give you thanks and we lift our praise to you. And we give thanks, we give praise, for we know that all things work together for our good. We give thanks, we give praise, for by faith we know your grace will see us through. We give thanks, we give thanks, we give praise, for we know that all things work together for our good. We give thanks, we give praise, for by faith we know your grace will see us through. For all those things that we don't understand,
We come by faith and we place them in your hands.
we give thanks, we give praise, for we know that all things work together for our good. We give thanks, we give praise, for by faith we know your grace will see us through. Even if we stumble, even if we fall, you will not forsake us. You are King and Lord of all, Lord of all. And we give thanks with a grateful heart. Give thanks to the Holy One. Give thanks because He's given Jesus Christ, His Son. Give thanks with a grateful heart. Give thanks to the Holy One. Give thanks because He's given Jesus Christ, His Son. And now let the weak say, I am strong. Let the poor say, I am rich because of what the Lord has done for us. And now let the weak say, I am strong. Let the poor say, I am rich because of what the Lord has done for us. Give thanks. Sing it. We give thanks with a grateful heart. Give thanks to the Holy One. Give thanks because He's given Jesus Christ, His Son, His Son. Give thanks with a grateful heart. Give thanks to the Holy One. Give thanks because He's given Jesus Christ, His Son. And now let the weak say, I am strong. Let the poor say, I am rich because of what the Lord has done for us. And now let the weak say it, I am strong, oh yes. Let the poor say, I am rich because of what the Lord has done for us. Give thanks. Oh, we give you thanks. We give thanks. We give thanks. Lord, I offer my life to you. Everything I've been through, use it for your glory. And Lord, I offer my days to you, lifting my praise to you as a pleasing sacrifice. Lord, I offer you my life. Let's sing it. Lord, I offer my life to you. Everything I've been through, use it for your glory. And Lord, I offer a pleasing sacrifice. Lord, I offer you my life. Things in the past, things yet unseen, wishes and dreams that are yet to come true. All of my hopes and all of my plans, my heart and my hands are lifted to you. Lord, I offer my life to you. Everything I've been through, use it, Lord. Use it for your glory. And Lord, I offer my days to you, lifting my praise to you as a pleasing sacrifice. Oh yes, Lord, I offer you my life. Sing it together. Lord, I offer, and Lord, I offer my life to you. Everything I've been through, use it, Lord. Use it for your glory. And Lord, I offer my days to you, lifting my praise to you as a pleasing sacrifice. Lord, I offer you my life. Lord, I offer you my life. Oh yes. Like a deer that pants for water, I am thirsty for you, Lord. And in my heart there is a longing. I still believe there's more. So open up the heavens and let your spirit fall like rain. Wash me in your presence, refresh my life again. A hungry heart is what I bring to the table of my King. For there my soul is satisfied with all the goodness He provides. All that I need is there by faith. The table is set with mercy and grace.
Good morning once again. So we're going to do another important exercise while waiting. We're going to rewind our African time and start with the tea break, then resume. So I hope it's not a bad arrangement. So we apologize for the delays, but kindly we are going for the tea break. we start and we go straight forward with the presentation. So kindly, the tea break is organized over this side.
Then I will
Are you guys seeing me? So let us go forward and enjoy that exercise while we are winding our time. Thank you.
I will rise on wings
and to do for 15 to 20 minutes. Thank you.
For the Lord will be my strength. A hungry heart is what I bring to the table of my King. For there my soul is satisfied with all the goodness He provides. All that I need is there by faith. The table is set with mercy and grace. So I come with a hungry heart, just as I am, without one plea, but that thy blood was shed for me. And as you bid me come to thee, O Lamb of God, I come. A hungry heart is what I bring to the table of my King. For there my soul is satisfied with all the goodness He provides. All that I need is there by faith. The table is set with mercy and grace. So I come with a hungry heart. So I come with a hungry heart. My heart is filled with songs of praise. You gave me hope. You made a way. Now I long to live in your presence for all of my days. My soul sings, my spirit shouts. With every breath, I'm crying out, I want to live for you alone. You have captured my heart, mi corazón. Lord, I give you my whole heart, mi corazón. Amazing grace has rescued me. You paid the price. You set me free. Yes, you did. I will sing your praises forever, my Savior and King. My says it's a good thing to give thanks to the Lord. Amen. I come before you today. There's just one thing that I want to say. Thank you, Lord. Thank you, Lord, for all you've given to me, for all the blessings that I cannot see. Thank you, Lord. Thank you, Lord. With a grateful heart, with a song of praise, with an outstretched arm, I will bless your name and thank you, Lord. I just want to thank you, Lord. Thank you, Lord. I just want to thank you, Lord. Thank you, Lord. You've done in my life. You took my darkness and gave me your light. Thank you, Lord. Thank you, Lord. You took my sin and my shame. You took my sickness and healed all my pain. Thank you, Lord. Thank you, Lord. With a grateful heart, with a grateful heart, with a song of praise, with an outstretched arm, I will bless your name and thank you, Lord. I just want to thank you, Lord. Thank you, Lord. I just want to thank you, Lord. Thank you, Lord. Thank you, Lord. I just want to thank you, Lord. Thank you, Lord. I just want to thank you, Lord. Thank you, Lord. We thank you, Lord. Yes, we do. For all you've done, for all you're going to do. Thank you, thank you, thank you. Yes, we do. Thank you, Lord. Thank you, Lord. Oh, we thank you, Lord. Yes, we do. is good all the time. He put a song of praise in this heart of mine. God is good all the time. Through the darkest night, His light will shine. God is good. God is good all the time. God is good all the time. He put a song of praise in this heart of mine. God is good all the time. Through the darkest night, His light will shine. God is good. God is good all the time. That's right. If you're walking through the
think after the very important exercise, we're all going to be more active. Good morning.
Call to him,
how are
he
you?
will answer us.
So we are
If
glad
we
to
run to
host
him,
and
he will
all be
run
welcome
to
at
us.
this first
We
Rwandan
lift
Surgical Research Open Day. A round of applause for all the organizers who have made this event possible. A small introduction about the Global Surgery Research Day was organized by the Global Research Hub of the University of Rwanda, which is a Rwandan chapter of the NIHR, which is the National Institute for Health and Care Research from UK, a research unit on global surgery, a multidisciplinary team of academic surgeons, clinicians, researchers, health economists, global surgery experts, and patients, representatives from the UK, Mexico, India, Ghana, South Africa, Benin, Nigeria, and Rwanda. This University of Rwanda aim is to become a research-led institution with research output locally relevant and internationally recognized by empowering as well national economic and social transformation. For that regard, the University of Rwanda signed an agreement with the University of Birmingham to establish a global surgery hub under the Department of Surgery, College of Medicine and Health Sciences. So as we welcome you all, the role of the hub is now to develop and strengthen research, including clinical trials. This Open Research Day will be an interesting day, as we'll be welcoming the keynote speakers. We'll be having multiple activities, including posters, which will be exhibiting various researches done. We'll have introduction on the clinical trial regulation, community engagements, very many activities. So you are all welcome to stay awake, to stay engaged, and there will be also a YouTube channel. So if you don't have it, I think we'll ask the IT maybe if you want to share it. And if you have anyone listening to us on the YouTube channel, you are welcome to ask questions as well. We'll be reading them openly once the sessions, the time for asking questions are availed. Without wasting much time, I would like to kindly and warmly welcome Prof. Nirenganya Faustin, who is going to welcome for us the keynote speaker and also introduce about the various different audience present with us. As I'm still a junior, I cannot be able to present it by myself. So maybe in 10 years. Thank you very much.
Thank you, Grace. Good morning, everyone. Good. Madam Principal, thank you for coming. Dear colleagues, ladies and gentlemen, it's a pleasure to me to stand here today and to welcome you all to this first Surgical Research Open Day. This day has been organized by the Global Surgery Research Hub of the University of Rwanda. It was, as it was mentioned before, together with different partners, including colleagues from the University of Birmingham and the Department of Surgery, College of Medicine and Health Sciences. I'm gonna just start by small introductions so that we know each other and we know who is here today. Can medical students stand up, please? Students, thank you for coming. Surgical trainees, residents, and colleagues. Thank you for coming. I'm gonna introduce our visitors from Birmingham, Donna and the team. So Donna is the senior clinical trial manager. Rachel and Mark, they are part of the team coming from Birmingham. I'm gonna Rwanda Surgical Society, here presented by the Secretary General, Dr. Christophe Mirimbanyi. Are you around? Okay, thank you for coming. We do have hospital directors Dr. Etienne Nshuti, Director General of Bushenge Hospital. We do have colleagues, heads of departments. Dr. Furaha Charles, Head of Surgery at Rwanda Military Hospital. Dr. Bikoroti Joel, Head of Surgery at the University Teaching Hospital of Kigali. Dr. Waisenge Justa from CHUB. Different colleagues from our spoke hospitals. I saw Dr. Ruhosha from Kabwai, Dr. Eric from Byumba Hospital. If there are other colleagues from spoke hospitals that I'm not citing, please stand up for recognition. Thank you, guys. We have one of our main collaborator in this business. This is the Rwanda Food and Drug Authority, here presented by Dr. Ndayambaje, which is normally a clinical trial analyst, but he is here now representing the Director General of Rwanda Food and Drug Authority. I saw, I think, Prof. Nkusi entering. Yes, Prof. Prof. Nkusi is the President of Rwanda Surgical Society. Please stand up for recognition. And maybe the protocol can move you a little bit in front. So, I'm not having a speech today now. Maybe I will speak a little bit later. This was just to welcome you and to take this opportunity to welcome Madam Principal for his opening remarks. Principal, the floor is for you.
Fellow researchers, scientists from the University of Birmingham, fellow researchers, scientists from the University of Rwanda, College of Medicine and Health Sciences, hospital directors present here, the Rwanda Society for Surgeons, all colleagues from other sectors like Rwanda, FDA, distinguished guests, ladies and gentlemen, good morning. We are here today, please allow me to say this. First, to celebrate the collaboration with the University of Birmingham. We much appreciate working together since we signed the MOU in 2018. And that led to what we are celebrating today, the creation of the Global Surgical or Surgery Research Hub. Thank you very much. Again, thank you. We created the hub. At the beginning, we didn't know that we are going to achieve what we're achieving today. But today, I was looking at the concept and then at the program. Today, we have research output, but we also have the research output with other people. So we are extending the collaboration, the partnership with other collaborators. It's wonderful. Thank you, and again, thank you. You're always welcome. The University of Rwanda aims to become a research-led institution. To achieve our mission, we need to have research output relevant to local communities and international community. But also, we need to recognize empowering our economy and always transform our society. To achieve this, we need to continue working together, not only with our partner, the many partners in this collaboration, but also with the other partners we are bringing on board, with the Society of Surgeons, with our colleagues from different hospitals, with our community. Together, we are going to achieve our mission. As many of you know, the Global Surgery Research Hub, Rwanda, is one of the 7 research hubs created through a collaborative grant obtained from the NIH from UK in 2016. The University of Rwanda is one of the sub-recipient universities. The coordinating institution being the University of Birmingham. We have similar hubs which have been created in UK, Mexico, India, Nigeria, Benin, and South Africa, and Ghana. The agreement established the Global Surgery Research Hub has been signed, as I said, in December 2018, and again, let me repeat that, we have achieved a lot. But let me say that the main objective of establishing the Global Surgery Research Hub in Rwanda under the Department of Surgery in the College of Medicine and Health Sciences was first to develop and strengthen the surgical research, including clinical trials, and promote the culture of evidence-based surgical practice. I keep on saying we have achieved, but what are the many achievements we are celebrating today? We are celebrating the collaboration, but we are seeing achievements coming day by day. So the many achievements, to mention only few, the strong and highly performing Rwanda networking with 13 hospitals. Thank you very much, our colleagues from hospitals. You have accepted us. You have opened your doors and say, here we are. You can come and we are going to celebrate and achieve together. Thank you very much. We are now counting 20 publications. Since 2018, 20 publications. I don't know how many, Professor Foster, Dr. Isai can say this. I don't know how many times we have celebrated 20 publications in few years. Thank you very much. Clinical trials. You agree with me, colleagues, we really have few clinical trials. We do research. Our university is the leading research college for this university. Our college is the leading college, research leading college for the University of Rwanda, but there are very, very few clinical trials. They will again agree with me. Thank you very much. The students and surgical trainees research support. Students, we celebrate you also today. Research capacity building in districts and provincial hospitals. The evidence-based surgical practice. From this, we have guidelines, we have policies. The priming studies. All these are our achievements. Now, what next? What is the future plan? Where do we want to go from today? We have plans. We need to translate research into policies. We need to have more collaborative research. Last but not least, confusing, on our plan to become a center of excellence. Yes, we can. We can. Not, the we is not we only, the University of Rwanda. We can, together with the Rwanda Society for Surgeons, we can, together with the colleagues from hospitals, we can, together with our beloved students, we can, together with our ministry, the Minister of Health, also the Minister of Education, but most importantly, with our partner, our colleagues from the University of Birmingham. Thank you very much. You are most welcome to have this center starting today. We can decide today. Today, we launch the center. It starts today, and it's going to be established. You have the support from the College of Medicine and Health Sciences, and I'm saying this on behalf of the University of Rwanda, the support from the University of Rwanda leadership. Thank you very much. Please, I need to end my remarks by emphasizing on 3 things. One, the first one is, remember always to consider research that brings impact. We have, my colleagues and we have done many research in our college. Some research they are kept somewhere, like novel books, or, they have been published. Articles are kept somewhere, or they are published in a big, when you finish the PhD, you write a big book. Then kept there. What for? So we need, like you are doing now, research that transform, that inform policies, that inform guidelines for our ministries, the Ministry of Health, the Ministry of Local Government. Hey, watch there. This is what we are bringing to you. Research that inform our teaching. Sometimes we forget transforming can start by what you are teaching. You transform where to teach. You train people with a new knowledge coming from the evidence-based you are getting from research. So, very important research that brings impact in different aspects. Secondly, the interdisciplinary, interprofessional approach. Very important. You are not doing this, not only you surgeons, but we are doing this with the nurses. I've seen you are doing it already. Thank you for that. Anesthesists, doctors, you are doing it already, and others. Then you become strong. And the impact is not only from you, it's the impact you are bringing together with the others to transform. Mentorship. You're doing it because today you're also celebrating the work of our students. Please continue that way. We much appreciate the involvement of students. Last, again, but not least, please join me to congratulate and thank Professor Foster and the team from the University of Rwanda and the team from the University of Birmingham. Thank you very much for your efforts. By the way, I forgot to thank you and congratulate you. I'm informed you won a new grant, and that is going to take you for 5 years. No struggle, no problem. Many achievements. Thank you. Congratulations. Professor Foster, when he wants me to push something, something he wants this to be done today, it's not going to leave my office, or it's not going to, it's just, I need this today. I want you to be here and help me on this. And that's how it is. Thank you, you and your team, for your commitment. I know how much you strive and you contribute to the development of the university in many things, not only research, but also training, coming up with new programs. I'm talking about programs, not only the teaching, but many things, community involvement, like when you go with the Operation Smile to community, do some interventions. All these are programs you're bringing to the University of Rwanda, but also to your country. Thank you very much. I admire what you're doing with your colleagues from your society. the Society for Surgeons. Thank you very much, Professor Ngusi. Thank you very much, Dr. Fura. We appreciate very much. We are so proud of you, so proud of the work you are doing. Thank you very much again. God bless you. Thank you.
Thank you very much, Prof. Kagwiza. Can we have a round of applause to her as she gave us for the beautiful opening remarks by reminding us the importance of research and the importance of the teamwork together with the University of Birmingham. As we continue, we're going to welcome Prof. Faustin, who's going to give us the overview of the. But before I welcome him, I would like to give a small overview as well. Once I was a resident, I'm a consultant in orthopedics. I'm based at Kigali University Teaching Hospital. When I was a resident, I met Prof. Faustin, and we were juniors. We were in first year, second year. And I remember before you meet him, you have a duty. You have to present in the morning about what you have studied, what you have. If you receive a case, you have to come in the morning and present in the morning stuff. And I remember that stuff was very fearful. So you learn, you study, you look at the patient, you go back, you revise again, you look at the most recent research. Then in the morning, if you ask you one question, then you find you have forgotten everything because you are fearful that you're not going to be, you're not going to excel or give an accurate answer. So we are grateful to you, Prof. Faustin, for the job you have done. If you have been educated by him, if you have been influenced by him, anyone? Yes, so it shows you how grateful we are for the grateful impact you have on the surgery education in Rwanda. So Prof. Faustin is an associate professor of surgery. He's the chair of the Department of Surgery at the School of Medicine and Pharmacy at the College of Medicine and Health Sciences. And he's also the director of the NIHR Rwanda Research Hub on Global Surgery. And he is a double specialized in general surgery and plastic surgery. He got his degree in general surgery from the University of Rwanda and the diploma from the postgraduate inter-university diploma in breast, oncoplastic and reconstructive surgery in Paris 9 University, France, and also a fellowship in COSEXA. He has more than 70 papers in local, regional, international peer-reviewed journals, and he also participated and presented in many international conferences. He's a winner of different awards and research grants, and he is engaged in global surgery as he strives for university access to qualify for healthcare, including giving access to high-quality, specialized surgical care to undeserved population. A round of applause as we welcome Prof. Faustin Nirenganya.
Good morning again. I'm going to give a Global Surgery Research Hub Rwanda, and thanking principal and colleagues for acknowledging that what we are doing. And this is really a team effort. So I'm just here representing a number of people that you will see. and there are so many. And I thank them for the good job they are doing and to help us achieve whatever we have achieved in the last 3 years. Are you sure the take is okay? Dr. Charles and colleagues that maybe we may have a discussion and see how Rwanda Military Hospital also joined the network. And the referral hospitals, we have 5 over 7, which representing around 71% of all the referral hospitals, which is a good number. However, we still have a few district hospitals. We only have 5 of them on a total of 36, and it is representing only 14%. This is an area of effort where we have to make people in district hospitals understand that research is part of their business, and actually they gain much by engaging in research. Even if looking at their own numbers or their own processes, it can improve tremendously the quality of care. So as one may say, when you don't count, you don't count. So about the achievements, Madam Principal highlights some of them, and that's true. We did a lot, but it was really a beginning, a steady learning curve. As you know, this was very new, and making people understand that we can do it as together. So because the word collective is important. So togetherness is very important in the new era of research, when you can be as broad as you can. We started engaging in clinical trials in 2019, and the first one was Falcon. So I will not go into detail about this because there will be presentations around the findings from these clinical trials, but I am just highlighting them on the administrative part of it. So Falcon was our first clinical trial, started in 2019 and was closed in September 2nd, 2020. So we involved in this trial 4 spokes, and we recruited around 839 participants. This is a closed and already published trial that we will be sharing the finding in a few hours to come. So we participated also in Talon. Talon was a sub-study from Falcon, and which also has been concluded and published. So as we grow, so the third clinical trial was Cheetah, and Cheetah, this one was a big one, and we grown with it to expand our network into 13 hospitals. And we put in this clinical trial 2,744 patients. And those how the numbers were distributed. And actually the majority of our hospitals achieved the ceiling of the trial. And some didn't, but they contributed to a good number. So in all the network, we are among the best recruiters. Maybe know that Rachel and the colleagues will talk about a little bit this later. But Cheetah was a success, and now it is being published. So currently we have Protect Surge. Protect Surge is another clinical trial, which is unique in its own because it is a COVID-related clinical trial. And this one is trying a drug. And this Recipe 301 is a new drug which is aiming to reduce the permanent complications for surgical patients undergoing surgery, either exposed or infected with COVID. So we started this clinical trial a few months ago, and CHK has opened, is now recruiting. The Kibagabaga Hospital followed, and after tomorrow we will be in Kibogora to start this trial there, and later we will go to CHUB as well. So this is really one of I'm proud of this kind of clinical trials that now we can do them in Rwanda. So we ran a number of micro studies, and those will be seeing displayed there on posters, or those that are going to be presented here as oral presentations. But our main achievement was to be part of a greater and bigger network of researchers globally. So we are part of Global Surge Collaborative. Global Surge Collaborative is a huge network of surgical researchers, which may be the first or the biggest in the world. And I think we had now the Guinness of record about the maximum number of authors on one paper. So maybe that will be also discussed later. But this is a huge family, and when you are together with people like this, you cannot only fly, because you are supported from here and there. This is one of our main achievements. So we are also part of COVID Surge Collaborative. This is another great network of researchers doing some COVID-related research around surgery. And we had a number of papers together with them, as well as a good number of papers with Global Surge Collaborative. If you see Global Surge Collaborative somewhere, so think we are part of it and we are in. So we have been a hub, and our regulatory authorities has been closely monitoring us, and that's why we are here today with the representatives from the Rwanda Food and Drug Authority, which the authority in Rwanda overseeing what we do as researchers, especially clinical trials. So we had inspections from them, and we got positive feedbacks. So they were my queries that I do humbly accept and say that we are learning, and as we learn, we may make few mistakes. But generally the feedback was quite positive, and we have been encouraged to continue what we are doing. So we received them to inspect Cheetah, we received them to inspect Falcon, and we responded to their queries, and we got a clearance letter saying that they are happy. So that's very good. We are starting something new, what we call community engagement and involvement in research. So in the past, people used to do research for the community. Means you think that you know better than they know. You think that you know better their problems, and you fix them and you bring them solutions. So this is outdated. So we move forward thinking that we should be doing research with them. So from the ideas and from the designs, the research concepts, so community should be included. So that's why tomorrow we will be having a big session about community engagement, training of trainers, so that we learn how do we engage community into research. So those who are willing to join tomorrow, they can join as well. So we are also organizing one project around that we call Pigeon, and I will tell you a little bit later what Pigeon is. And this is starting, and it has already started actually. So we run finances, as people may understand, that grant management is not an easy thing, but we have very able teams from the SPIU of the University of Rwanda, but also we have our own finance specialists that we hired, and that is working for us as a hub. So we run a number of budgets. There are hub-related kind of budgets, but also we have specific study budgets that comes as we get a small or bigger grants for different studies. So now, what our 5 years next strategy? We think that in the next 5 years, we wish to see the hub becoming a center of excellence, engaging more in innovations for health transformation, which may include but not limited to evidence-based interventions community engagement and involvement, and creating sustainable education and training solutions and opportunities. So that is our vision for our next move. And we have a strategic plan which is axed on 4 main pillars. One is health system strengthening. We also gonna work a lot about evidence-based surgical practice. We will align our doings and whatever we think about with the national strategies. And what is interesting to us more is different strategic documents that Rwanda has adopted, like the National Surgical Obstetric and Anesthesia plans, that we are going to try to see how we do implement them and how we monitor and see it is going well. And we want also to impact on the community and the policies. So that is the main strategic plan. And we will have different articulation about research and innovation, career development and leadership, community engagement and capacity building. And it will be delivered through a structure of the hub, which we look like this, where hub lead and different people around him will do whatever it takes to deliver the plans. So in this plan, there are main activities. And as I was saying, around health system strengthening, where we want to build a multidisciplinary and inclusive approach to deliver services. We have to find ways of generating accurate data for surgery. And as you all know, the policies and the policymakers and the politicians, they don't look at you because you are tall or short. They are much more interested on your data. So you should be bringing data if you want to discuss and to be relevant. So that's what we should be doing as a surgical community. So we will invest a lot as in the different areas that I have been highlighting in the previous slides. So I want to a little bit stay on this slide about the impact, because I was happy that Professor Kagwiza, our principal, highlighted that we should be doing research which is impactful. So we are a university, and if you go into our cupboards and wherever, you will find a lot of papers. And some of us are promoted based on that, but you should be transforming someone's life if you really think you don't do research to do research. We do research to impact on people. So impact is going to be a big thing, and we want to impact more, not only to reach into our university as the University of Rwanda, trying to build our internal capacity, trying to share whatever we have with our colleagues, and trying to be happy to take a hand of anyone so that we can move together. So we want also to impact on outside the university and create another number of partnerships. And at the end, try to translate research findings into policies. That's why policymakers, ministries, regulatory authorities are always welcome into our gatherings so that we can discuss, exchange, and maybe share some findings. So, but we are going also to be organizing on a regular basis events like this, where we are going to be disseminating research findings so that those who cannot read, we can read for them and then tell them what we found. So Pigeon, as I was saying, is a project that we really want to run, and we are doing it. And it's looking at improving such outcomes through active involvement of the community. So as you know, Rwanda did a lot in the maternal health and the other fields using only community health workers, and they did the wonders. But surgical-wise, we don't have anything for them. And we think that surgery is complex. If we're still thinking that surgery is complex from our standpoint, that no one can help, then we are done. We should be finding something they can do with us or for us, so that we improve on the outcomes. So that is the task I'm giving to you all. Anyone who has an idea what a community member, what someone in a very remote village can do so that surgery is improved and surgical outcomes are improved, please, there was a link shared for recommendations. If you can enter that into that, you can give us ideas about what you think the community should be doing to improve surgical outcomes. So that, I think, is going to be my last slide. And before this just conclude, so I just repeat this. In the next 5 years, we wish to see the hub engaging more in innovations for health transformation, which may include but not limited to evidence-based interventions, community engagement, and creating sustainable education and training opportunities. Furthermore, Global Surgery Research Hub Rwanda is looking to establish a new partnerships, translate research findings to policies for improved evidence-based surgical care practice in Africa and beyond. Thank you very much.
A round of applause to Prof. Faustin Nirenganya. Yes, for reminding us that tight collaboration leads to impactful clinical trials, and also that reminding us we should be more involved into having a seat with stakeholders to have more meaningful decision making, which will improve the surgical delivery to our population. We are going to the next session, which will be the first session on presentation, which will be on emergency surgery. We are welcoming the moderators. Our first moderator is Dr. Isayi Nshogoza. He is a senior lecturer and senior consultant ENT surgeon. He is the head of Department of ENT at the School of Medicine and Pharmacy, College of Medicine and Health Sciences at University of Rwanda. He is also the Deputy Director of NIHR Research Hub on Global Surgery Rwanda chapter. He also holds a specialization in ENT from the University of Rwanda and a fellowship degree from COSEXA in otolaryngology. And he also holds different certificates in otology and endoscopic sinus surgery training from regional, international universities. And for the last 8 years, Dr. Nshogoza Isayi has been active in the training and competent training of ENT surgeons in the country, and also through COSEXA. He has also been a researcher and published more than 15 papers in local and international recognized peer-reviewed journals. And he has also contributed in research projects within the University of Rwanda and NIHR Research Hub. We are currently welcoming Dr. Isayi Nshogoza. We are also, he will be co-moderating together with Mrs. Esperance Muhawenayo, who is a registered nurse with, yes please, with a Bachelor's of Science and Master's of Science in Nursing, with a medical and surgical nursing specialization. She is a honorary clinical lecturer in the medical surgical nursing track, School of Nursing and Midwifery at the University of Rwanda. She is a research associate, Global Surgery Hub Rwanda, and she has been participating in different research studies. She is also have been in the multiple studies, including the surgical risk of a patient with COVID-19. She has more than 11 years in leadership position. She's the matron of the surgical department and at the Kigali Teaching University Hospital, and she has more than 5 years of experience in conducting surgical mobile camp and outreaches. She has also have multiple trainings on clinical guidelines, clinical audit, policy, and procedure development. She is a champion in building nursing career and a member of the National Council of Nurses and Midwives, and a member of the Professional Code of Conduct Committee. Warmly welcome together Dr. Isayin Chogoza and Mrs. Esperance Muhawenayo. So as they are moving forward for the presenters, this laptop, there will be all your presentations. So you don't need to bring your own laptop. You'll just open and you see your respective topic available. Thank you.
Thank you, Grace. For time catch-up purposes, I would like to invite the presenters, and we have this session is emergency surgery session, and we are going to receive 6 presenters. There's Dr. Allen Ingabire is going to start, and is going to talk about mortality of emergency abdominal surgeries in high, middle, and low income countries. Kubgimana Olivier will follow, and then Sam Byakagara, and Christophe Mpirimbanyi, then Nigaba Gilbert, and Christophe Mpirimbanyi will follow. We'll end the session. So Dr. Allen is welcome. So you have only 10 minutes. Then we give time to the next presenter. You are welcome.
Good morning. I think they are going to display my presentation. Actually, this is the paper that I'm going to present. It has been done in the Global Surge 1. And this paper is the pioneer of the Global Surge. It's the one that we have started on, and it has done all of this that you are seeing today. I remember when we started on this, it was in 2014. And before that, I met some colleagues from Birmingham at the Betun round table, and then we discussed about which topics actually that we can be doing in the low and the middle income countries. And later on, we started this. You will see it's really amazing, and it has gone through with all of now we have. So this is a mortality of emergency abdominal surgery in high, middle, and low income countries. Although I'm an orthopedic surgeon, but at that time I was doing abdominal surgeries. And this is a global surgery collaborative that we have done so in 58 countries. Like you know, we are having more than 17 millions who were dying across the world from the surgical disease. That was in 2012. Probably now it has changed, but this paper was initiated at that time. And 1/3 of the world population only they have access to safe surgery, affordable, and also timeline. You can just see the low and income countries. They don't really have access to this surgery, even though we are having a big number of the population which is really in need of surgery. The surgical mortality actually in the high income countries is collected routinely. But when you go in our database, surgical database, and wherever we are, it's very hard just to monitor and to see what we are collecting on a routine basis. So the aim of this study was just to see the worldwide mortality in high-income countries, the middle-income countries, and also low-income countries. And this we have just used the Human Development Index. This was a prospective multiple center cohort, and what I can say here, it's actually for the global surge. We are not running only the clinical trials only. This was in the global surge 1, which is taking like a cohort, but each country, each hospital can choose which week that is going to collect the data. This was the global surge 1. The global surge 2, there is a colleague in surgical site infection who is going to present on that. And they also was a cohort. And the global surge 3 also was a cohort where we were collecting about the cancer. So this we collected, it was a cohort, and then was a 2 weeks interval of collecting data and also following a patient at 30-day post-operative. We, like I said in the beginning, we had 58 countries. We had 375 centers, hospitals, and we collected more than 10,000 patients in 2 weeks of collection. So half of them were in high-income countries. Middle-income countries were counting almost 3,000, and low-income countries were just collected. We collected almost like 6,000 of the patient. And the primary outcome of this was post-operative mortality, and secondary outcome, we looked at the 30-day mortality, post-operative complication, and then also the reintervention. So for the results, actually, this was an amazing paper. Even though we have in the global side other papers which has scored very high, like the COVID ones, and also other systematic, but this was our first paper which scored high with a long list of the co-authors, and we have found that trauma was the indication for surgery in low and middle income countries. So it was at the first line, and the appendectomy, even though now appendectomy is changing to be managed conservatively, but across the world, at that time the appendectomy was the most commonly performed procedure. And what was surprising, it was also the midline laparotomy. We found that was even being done in high-income countries, even though we were probably at that time thinking that they are doing laparoscopy. And the surgical chef list at that time was done in 70%, and the overall mortality was ranging like it's displayed. High-income countries, they were the ones who were having the low rate of mortality, and the low-income countries were at 3.24%. When we looked, this was up to 24 hours, but when we followed the patient 30 days, we found that the mortality has been increased almost by 5.4. It means that sometimes we discharge patient in a post-operative, but when you don't follow them within after discharge, some of them, they die even without knowing that what is happening for them. So it's why you have found that in low and income countries, the mortality within this time was 80.6. And also, after adjusting, always we have found that the mortality in 30 days was really very high in low and middle income countries. For the discussion, the mortality rate after abdominal surgery is almost 2 to 3 times higher in low compared to high income countries. And almost more than a half patient, they die in post-operative, they die after discharge from the hospital. And the appendectomy was the most operation done. In the low-income countries, the mortality, high mortality was seen specifically after laparotomy for trauma. And there was been other studies done for this. For the conclusion, the mortality, like I was saying, low-income countries was really almost 3 times when you compare to others. And access to surgery is really very poor. And patient safety factors, they can have an important role. For the recommendations, these recommendations, they are the ones which has generated the others. We were looking at if we can create a strong network to decrease on this mortality. I think it's what we have created with the global surge. And also, it was to move forward with evidence-based to identify the cost-effective intervention which can reduce the disparities in outcome after surgery between the countries. And all of these guidelines that you are seeing here was created from the Global Surge 1, Global Surge 2. This one was preventing surgical site infection, and now it's really widely cited and used in many countries, not only in low-income countries, but also in high-income countries. And this one for the COVID surge, also my colleague will talk about it. So thank you very much.
Thank you so much, Dr. Aren. You have respected the time. You used only 7 minutes for your summary. So I take the opportunity to invite Kubwimana Olivier, who is a senior resident in orthopedics, and is going to talk about effect of ACE ankle brace compared to back slap. So compared to back slap in management of acute lateral ankle sprain, it's a prospective cohort study. So you have 10 minutes.
Thank you so much. I'm Dr. Kubwimana Olivier, a resident in orthopedics, and this was my memoir. I hope it's coming. So the title is it's not that one.
Si tu t'en vas, j'irai cacher mon mal de toi dans un désert ou dans le ventre de la terre. Honte sur moi si tu t'en vas, si tu t'en vas, ma belle de toutes les douceurs, si malgré moi
So we apologize for the inconvenience. Thank you. So the title is Effectiveness of Aircast Ankle Brace Compared to Backstrap in the Management of Acute Lateral Ankle Sprain. It's a prospective cohort study, and I pay tribute to my supervisors. So as an introduction, ankle sprain is a traumatic overstretching or tear of the ankle ligamentous complex. It can be either medial or lateral. It is very common among sports injuries, and it accounts around 5% of UK emergencies, and most of them are lateral ankle sprains. And it is not only a clinical entity, it is associated with enormous economic expenditures, many in Western world. So the diagnosis is purely clinical, looking at the ecchymosis around the ankle, the swelling. You can do the anterior drawer test, as you can see on the right top corner. The tala tilt and also the delayed physical examination is the gold standard, which is done on the 3rd to 5th day. You can classify it as basing on the Western point classification. So imaging are reserved for complicated or pre-operatively. Among the treatment options, non-operative options has got a wide room whereby there is something called the RICE, which is rest, ice, compression, and elevation. And then you associate it with non-steroid anti-inflammatory drugs. Obviously, you have to immobilize the limb. You can either use the backstrap or an air cast ankle brace. Some other centers use a walking boot. And after immobilization, you have to treat the limb with physical therapy. So operative treatment has got a narrow room, but there is a procedure called modified Broston procedure, which is also done. So in our region, we have a positive data in regard to this entity, and that's why we conducted this study. So those were my objectives, to compare the outcome of grade 2 and 3 acute retro ankle sprain patients managed with backstrap versus air cast ankle brace at Sashika and King Faisal Hospital. Specific objectives were to look at the proportion of patients who were having pain and swelling after treatment, and also the rate of ankle instability, and to look for the timing of return to activities. So the study was conducted at Siashwika and King Faisal Hospital. It was a prospective cohort study. We included adult patients above 18 years of age with grade 2 and 3 acute lateral ankle sprain. We excluded patients who did not consent, patients with open injuries, patients with recurrent sprains, associated distracting injuries, incompetent patients like psychosis, patients with associated fractures, or patients who are not suitable for immobilization. So, upon confirmation of grade 2 or 3 acute lateral ankle sprain, the patient was treated either by a backstrap or an ankle brace, but this was a decision of a physician, a treating physician. So we calculated the sample size with using the cohort studies formula. In total, we got 90 patients, which were divided into 2 groups. And we used the data collection form with various variables. Data were analyzed using SPSS version 18, and we used some statistical tests. And we obeyed to ethical conduct. We obtained ERB approval, consent form, and we confidentially stored the information of the patients. So as a result, we obtained 90 patients, 71 patients from Siashwika, 19 from King Faisal. And here you can see the results are presented in a comparable way. So there is the backstrap group in blue and ankle brace group in black. You can see, looking at the age, the median age for the patient treated with backstrap was 42, while for the ankle brace was 45.5. And you can see the male to female ratio was 0.87 for the backstrap group versus 1.4. So for the West Point grading, it was similar in both groups, but this was not controlled by the investigator. So the common mechanism of injury that was found was a twisting and rolling ankle, which is inversion and plantar flexion. Running on inversion and plantar flexed foot, around 73%. So as primary outcome, there was improvement of pain that was favoring ankle brace group at the 3rd and 6th week post-injury versus backstrap. The swelling was also favoring the ankle brace, but it was not statistically significant. Other secondary outcomes were not statistically significant, including instability, which was similar in both groups. And the restoration of weight bearing was also favoring ankle brace, but it was not statistically significant. So as discussion, patient characteristics were different in two groups, obviously because it was an observational study, and a large number of patients were recruited from Siashika, given that it is a trauma center, and there were some similarities with previously presented study. Like we saw a large number of ankle sprain patients, which was also reported by POSA, and inversion and plantar flexed foot as a mechanism of injury, which has been also previously reported. Ankle brace being superior to backstrap in eye pain control, but also there was some differences from our study, like primary outcome at the 3rd and 6 weeks, which was favoring ankle brace. It was not seen by Benon. The cause of injury in our setting was more, the injuries were more in non-athletic population, or they were caused by road traffic injuries. But Fong et al. They found that this entity is very common in athletic population. So as conclusion, acute lateral ankle sprain is very common in Rwanda, and the occurrence seen even in non-athletic population, including senior citizens. Running on inverted and plantar flexed foot is the first number one mechanism. You can see the image, and the use of air cast ankle brace is superior to backstrap in eye pain control. So as a recommendation, we recommend to implement ankle sprain management protocol at Siashika and King Faisal. We recommend a semi-blinded randomized controlled trial. We recommend the hospital to avail air cast ankle braces, to retain more physical therapy, to train more physical therapists, mainly at DH, and how to rehabilitate a patient with ankle sprain. Referral should also organize visit to DH in management of acute ankle injuries. So we should also obey to Ottawa ankle rule while examining a patient with ankle injuries to reduce unnecessary radiograph. So those are my references. I thank you so much.
Thank you so much, Dr. Olivier, for the good summary and conclusions and recommendations. So to gain time, I would like to invite Dr. Sam Byakagaba. Is presenting on pooled analysis of WHO surgical safety checklist use and mortality after emergency laparotomy. Supposed to be presented by Bernard Mutoniwase. They are both coming from Chibogora District Hospital. You are given 10 minutes. Try to be in the limits. Thank you.
I'm Dr. Byakagaba Samuel. I'm a junior consultant in orthopedic surgery, and I'm heading the team of Kibogora Hospital. So if you wonder why I'm going to present about pool analysis of WHO surgical safety checklist use and mortality in emergency laparotomy, it's because I'm going to focus on checklist. And yes, orthopedic department use that. So as an introduction, the volume of surgical procedure performed now worldwide are increasing and it's large, and it is understandable because the population are growing. We are developing. The country is going to develop, and this expose patient to surgical care, and every patient who needs surgical care are exposed to risk of morbidity and mortality caused by the procedure itself. So the safety of surgical care remains a pressing concern in both resource in rich and poor settings. And despite the fact that WHO is encouraging people to use checklist, and now it's 10 years, I've seen that the implementation first time started in 2009, so now it's around 12 or 13 years. And despite that there is a dramatic improvement in terms of outcome, they will still have some numerous barriers to the implementation. And one of them is a dynamic education and social factors such as ambiguity and confusion. A lot of people doesn't understand just what is surgical safety checklist. Also negative attitude. I have seen a research done in obstetric emergencies. They even find, I was surprised, to say that 1/3 of the team are just resisting to use this checklist. And also, setting where resources are limited, and that can be understandable. So, although data supporting effectiveness of checklist in foresting improved surgical outcome are encouraging, studies globally representative the population are still uncommon. So furthermore, checklist outcome has been studied, but it were more in elective surgery. But now we are going to also extend the research to the emergency care. So our aim of the study was to evaluate the reported checklist used in emergency setting and examine the relationship with operative mortality in patients who had emergency laparotomy. As well as we are going to compare it with patients undergoing emergency laparotomy and elective gastrointestinal surgery. So the method, it were done in two multinational prospective observational cohort studies. 2 why? Because the data were collected in 2 different periods by Global Surgery Collaborative, and 76 countries were included in the study. And also the primary outcome measure was 30 days perioperative mortality. And I think this is the main and only variable we are going to discuss about. So this is the result. Here we are just, it's a graphic representing the patients who were included and excluded to the study. So at the beginning, the patients were 26,228, but only 12,296 fulfill the inclusion criteria for the study. So also we divided, this is also as a characteristic, patient coming from high HDA. HDA means Human Developing Index, which is, I think, is a new name or new qualification to mention developing country from developed country. And we found that in high HDA countries, we collected the number of the patients who fulfilled the criteria of inclusion were 7,048, and the middle HDI 3,685, and on the low HA we have 1,563. The 5 results we're going to discuss about the demography and the use of checklist, I hope you can see. Concerning the agency, we have emergency laparotomy and elective surgery. The checklists were used at 73% concerning the emergency laparotomy, against 26, which still a high number. And also in the elective, 71 against...
And sorry for inconveniences. Now I would like to call Dr. Christophe Mirimbanyi come and talk about extended spectrum beta-lactamase carriage and development of surgical site infection in Rwanda and Rwanda surgery patients. Try to respect 10 minutes. Of course, if I'm talking about time catch-up, it's like it's causing inconveniences. So let's just encourage the presenters to respect the minutes and give the important points.
Thank you, the moderator, for this opportunity to share with you the preliminary results of study we are conducting. So, as they said, I'm Christophe, I'm a general surgeon, and I work at Kibagabaga Hospital. So, surgical care constitutes a vital component of our national health system, and its importance has been increasing and is being recognized progressively. So previously we have done different researches in regard to surgical infections, and we have seen that based on the findings of previous surgical researches we have conducted in surgical infections, we have seen that there is increased antimicrobial resistance nationally, but also even globally. And there is also a shortage of available antibiotics agent for treatment of mainly of gram-negative pathogens. And seeing in our country, even globally, there is also shortage or limited antibiotic choices. Therefore, there is a threat globally that the antimicrobial resistance is increasing progressively if nothing is done. We have seen that among those studies conducted, the cephalosporins, which are actually the main third pooled antibiotics we have, the main big, strong spectrum antibiotic agent we have, it's resistant at 76% in surgical infections patients. And among the findings we have seen also there are SBR, which is also increasing. And there are also high rate of surgical site infection, whether the patient presented in critical ill or they delayed to present, or whether they have been exposed to antibiotics before. So we are seeing that bacterial colonization in skin and mucous membranes, they may later on become pathogen and be responsible for development of surgical site infection, for those who has been operated on. And some studies which were done, like in University Teaching Hospital of Butare, they screened in 2017 and found that there were 50% of colonization of patients with who developed SSI, and also 37% they were SBR positive and developed surgical site infection. However, we have seen that when we saw this result, we wondered, is being a carrier of SBR a risk of developing SSI? And then we decided to conduct this study, seeing at emergency surgical care patients who are being operated on, and those screening and whether they are carrier positive for SBR, and see those who develop SSI, surgical site infection, and also look for the linkage between the two. This is a prospective study that we started at University Teaching Hospital of Kigali, Sashika, at the starting of this year, and we have also started to expand into Kibagabaga Hospital. Initially, we started for acute care surgery, adult patient 18 years and above, but we are also planning to extend to gynecology obstetrics for those who have emergency cases and pediatric unit. So we so far had 28 cases. These are few because we had started at Sehashka in acute care surgery only, but because it's a 3-year period, we are also extending to other units, mainly pediatric surgery unit and also gynecology obstetric department, and we are also expanding to Kibagabaga Hospital to see whether they can meet the sample size within the study timeline, which is the 3 years. What we have seen so far is that we have seen 11% of infection for those who have been operated on, and those who were SBR positive were only saw 1 case. Of course, the data are still few, but we are still collecting. This is ongoing research that will give us a result for a better policymakers and also help us in antibiotic stewardship programs in our different institutions. I think that bacterial colonization of the skin mucus in the surgical patient may become a resistant pathogen, especially SBR positive, and they may constitute a risk of increased resistance to third-generation cephalosporins, which are the main high-spectrum antibiotherapy we do have in our settings, and also may lead to worse outcome if nothing is done. And therefore, we do need to, we are still collecting data for this study and see where we are and whether what we are thinking our hypothesis is true, and also have conclusions that will help us to strengthen the stewardship antibiotic programs in our surgical patient. Thank you.
Thanks, Dr. Christophe. Let's call upon Dr. Nigaba Gilbert. Gilbert is a junior consultant at Gisenyi District Hospital and is going to talk about effect of delay of care of patient with craniomaxillofacial trauma in Rwanda. You're welcome.
Morning again. I'm Nigaba Gilbert, as I said, ENT junior consultant working at Gisenyi Hospital. So I'm going to present on effect of delays of care for patients with craniomaxillofacial trauma. So as an introduction, craniomaxillofacial Okay. Craniomaxillofacial trauma represent a significant global disease burden which is affecting mainly lower and middle income countries where care is often delayed. And the younger people are commonly affected, and male are more affected than females. And the delay is defined as each patient is treated more than 3 days after presentation. And the cause of delay is especially when there is a surgical workforce crisis, and also we investigated the delay for craniomaxillofacial trauma in a large hospital like CHK, where there is treating mainly patients with the craniomaxillofacial trauma. And our study was prospective cohort study, and all patient, we recruited patient from June 1st to October 1st, 2020. There was no patient we excluded because all patients signed consent, and we found approval from ERB, from CMHS, and the ethical committee of CHK, and the demographic data was recorded, and the reason for delays was recorded when the patient admitted, and the data was corrected by the investigator, and the complications were assessed over the follow-up of 6 months, and we used univariate and multivariate logistic regression to assess complication, and we used the stata for analysis, and also we used Google map of Rwanda to assess where the patient were coming from. So for our results, we found that the male was commonly affected at the 94%, and the younger people was affected between 15 to 30 years, where 46% was affected, and the most common patient was coming from rural areas at 63%, and most patients were in a category 3, Rwanda in category 3, socioeconomic category, and the motorcycle was most commonly the cause of trauma, and we assessed for influence of alcohol, where we found that at 18.5% patient was have consumed alcohol at the time of injury. So for the injury characteristics, we found the mandibular fracture was most common, and also found the rib faults and the nasal bone and the frontal bone soft tissue injuries. So for the assessment for the delays, we found that all patients arrived at the most of the patients arrived at the CHK in 24 hours, meaning that they didn't delay because all patients was having insurance, mutuelle de santé, but at the time of treatment there was delay of 70.9%, and the cause, there are two main causes where the surgeon, there was a surgeon unavailability and the material problems which caused those delays, and most of the patients treated at 75% above 3 days, and the treatment which they have been receiving, there is a cross reduction which was associated with the Christmas, because cross reduction was most commonly associated with Christmas. So for this table is showing us the statistical significance of those problems. We found that the patient who was coming from far, for every 1 kilometer, the patient was associated with delay, where they found that it was statistically significant. Alcohol also intake was associated with the delay, and the alcohol delay treatment also, and the complication was statistically significant for the patient who have been delayed treatment after 3 days. So on discussion, we found that for the age, our population is young, so that we found that for the age, we have a younger age affected. And the characteristic of injury, we found mandible to be fractured because it's a prominent bone on the face. Sex male was affected because they are the one who most commonly riding motorcycles. And the cause of trauma, we found that the motorcycle was the most common cause, because in our lower middle income country, motorcycle are mostly commonly used. And the time to presentation, we found that the patient didn't delay because all patient was having mutual descent, which is a good point to, on our country. And the cause, the delay presentation, so we time to delay to treatment, we found that 79% was delayed, and we found that there was no maxillofacial surgeon, enough maxillofacial surgeon we have, and also material problem. And the cause of delay, we found that there was also, we said above, and the complication, the most common complication found is trismus, because almost the patient who have been treated by MMF was associated with the trismus. So for conclusion, we have the delay in treatment for craniomaxillofacial trauma, more than 3 days associated with increased of risk of complication, and also the delays in care were most commonly caused by transfer from district hospitals where they don't have those surgeons. We recommend to avail materials in the hospitals, also to train maxillofacial surgeons, also if possible to recruit maxillofacial surgeon, also to make awareness in the population to use helmet which can covers mandible bone so that cannot be fractured. So thank you for your kind attention.
So the next presenter on this session is Blaise Habineza, and is going to present on epidemiological profile and factors influencing post-ban in Rwanda. So you are welcome. And try to respect 10 minutes.
Good morning. So my name is Dr. Blaise Habineza. I'm a PGY4 resident in general surgery. So the title of my study is Epidemiological Profile and Factors Influencing Post-Ban Contracture Formation in Rwanda. So, so according to the WHO, ban injury affects almost 250 million of people each year, and cause death of 250 million each year. And also it caused the loss of 18 million according to disability adjusted life years. So it is 7 times more common in low and middle income countries compared to the high income countries. So, so the inevitable sequel of ban scarring is associated with one or more added post-ban contractures. So this is so these complications affect the social and psychological and economic aspect of the patient because of stigma and loss of range of movement. So there is also limited performance on activity of daily life. So also lack of early surgical treatment and rehabilitation. These lead to the need of reconstruction. So the purpose of this study was to describe the epidemiological profile of patients with post-burn contractures and to classify post-burn contractures seen in Rwanda, and also to identify factors that influence post-burn contracture formation in our country. So as a study design, we have used a retrospective cohort study, and the patient which has burnt in the joint and has been treated at CHUK and at Rwanda Military Hospital, and then patient who consulted for post-burn complication, especially in the joint, were included. So those who developed contractures and those who didn't were compared, and a total of 387 patients who had burn in the joint were included, well allowed, and the questionnaire comprising demographic and socioeconomic and behavior and clinical variables were used for interviews, and a system MASCA classification, which is morphological African skull contracture classification algorithm were used, and it has been found to be adapted to the developing countries, as other tools use technological tools which are not available mostly in developing countries. So SPSS was used for statistical analysis, and Pearson chi-square was used for statistical significance, and the confidence interval of 95% and p-value of less than 0.05 was used. So as the results, 313 patients developed post-burn contractures and 74 didn't develop. So the biggest, the most affected group was patient below 6 years, and it was at 9.8, and the median age was 7. Female were most affected than male, but according to the contractures, there's no, they are equally affected, and so 55.3% of the patients live far from the district hospitals, and most get care to the nearest health centers. 97.4% used insurance, so there is a high insurance coverage, and the dedication on physiotherapy and exercises at discharge from burn wound management was only 55.8% and 57.4% respectively. Patients who kept physiotherapy and exercise and regular session of physiotherapy and sprinting was at 9.1, 30.2, 17.8, and 9.6 respectively. So the main etiology for burn was scarred, and 22% of participants had graft in the joint, and the main kind of skin grafts was meshed split thickness skin grafts. So among those who had post-burn contractures, more than half were having MASCA type B. So MASCA type B is when a skull contracture band is narrow and low, so which allow few range of movement. And type C was 30%, which was narrow and high, mean wide and low, and type D was 11.5, which was wide and high. And type C and D are severe contractures. So the education on exercise and physiotherapy and patient keeping these were associated with reduction of post-burn formation with odd ratio of 0.5, 0.57, and 0.4 and 0.35 with p-value of less than 0.05. The sprintage adherence alone was associated with odd ratio of 1.0 and the p-value was elevated. So, so as the discussion, children are mostly affected and this is similar to other studies, and this may mainly due to the children who lack judgment capacity and who has poor movement coordination. And in low and middle income countries, there is low surveillance from the parents. So gender, as I said, are equally affected. Also, this is similar to other studies. They are equally affected about contractors. And also other factors such as lack of access directly to the hospital, lack of money, and geographical barriers. And also these factors affect the formation. So the MASCA tool is useful because it can help surgeon to plan ahead and to choose the reconstructive procedure. So it is. So also a lack of rehabilitation is associated, as I said, in general with post-burn contractures, but also the adherence to one method of rehabilitation is not enough. So the combination of all rehabilitation techniques is synergic. So as conclusion, post-burn contracture is a burden and non-complication of burn. So the occurrence in our settings associated with lack of early surgical treatment and rehabilitation. Children are most affected, and MASCA is a useful tool which can help in our settings. So as recommendation, we recommend education and training to healthcare providers and to the general population about burn prevention and post-burn rehabilitation because prevention is better than cure. Thank you.
Thank you for your presentation. So this is the end of the first session. The first session which passed through the abdominal surgery to the ankle, to the maxillofacial, to the burn, and then to the checklist and a bit about infection. So now is time for questions, recommendations, just a kind of discussion. We have 15 minutes. I see Prof. Faustin has a question, and see the hands of Dr. Furaha. So let's start by Prof. Faustin, then move to Dr. Furaha and Dr. Joel.
Thank you very much. For the sake of the time and share with the others, maybe I will pick two, which are much more burning to me. So one goes to Dr. Allen from the presentation on global surge 1. Maybe the question is out of the scope of your presentation, but I wonder how we can extract individual country and the individual hospital data so that we don't speak globally sometimes. So it is always good to go global when it's about significance and data and statistics. And is that what we put together 10,000 patients, it's huge. But what about Rwanda? So, and then the second question goes to Olivier, who did a good job on the comparison of air backslab and the traditional casting. I have seen you on all the comparison you did. What about the cost? So how do those two methods compare cost-wise? Thank you.
Thank you for good presentations. My question is directed to Olivier. You have compared a backslab to that, I don't remember how you call it. Yes. But I wish you could have compared like 3 with the full cast. Why didn't you compare with the full cast as well to see which one would be better? And or has it been done before? Because I guess a full cast would be better than any back slab or any slab. But that is a guess. That's why I wish you could have done a comparison of the 3 so that we get some insight on it. And just a comment about burns. Most of the patients of burns that we get are children, and for adults, there are people with uncontrolled epileptic. So it makes, I want to emphasize on the prevention part. In terms of, for the children, the reason in HDI, as they say, there is less burns. One of the reasons is just the way we cook. When we cook at high top tables where the children cannot reach, you get dramatic decrease of risk of burn. The issue with us is that we are still cooking on the ground, and children have access to or bump into those hot liquid. So the only fact of having your kitchen or cooking tabletop cooking just decrease dramatically the burns of children. But even for us who has houses with that kind of kitchen, we still using cooking outside. And I just wanted to mention that because in the prevention of burns, the way we behave or the way our settings in our houses are influence the risk of burn dramatically. And the other one, obviously, we have many adult patients who get burns because they're epileptic and the epilepsy is not controlled. If it was just controlled, those patients wouldn't get burned. And once you get burned, the best treatment or the best first aid is to pour tap water on the patient. Just tap water or any water that you find, not cold water from the fridge, but just tap water. It will decrease dramatically the severity of burns.
Thank you for all presenters. Just my small question or comment goes to Dr. Olivier and the team. You did a nice job. This is a good study. The just small question is, you are comparing a non-operative method for ankle sprain using this air cast ankle brace and the back slab. This is a non-operative. But I'm worried because you are comparing those people who are in grade 2 and grade 3. I'm thinking maybe you may have more biases because regarding these grade, you are comparing two heterogeneous group, grade 2 and grade 3. It could be better if you could compare this non-operative method to one group, either grade 2 or grade 3. At that time, you may have a good result, and statistically, you may be able to generate a conclusion. Otherwise, you may have a difficult either in statistic method or statistical tests, even a conclusion. Thank you.
Thank you very much to all presenters. Mine goes to maxillofacial. You know, that's coming from a lay person, eh? So don't think I'm questioning you deep because I'm not a maxillofacial surgeon. The delay. As practitioners, we know when we call MaxFax to see a patient with swollen face, we are told that you wait for the swelling to go down. Now today I'm surprised that delays of 3 days. So what is the discussion? Because you always tell us the swelling must go down. Well, the problem is that you are ENT, so I may not get the answer, but it's just maybe you read about it. Because when we consult, they tell us to wait for the swelling to go down. I suppose we know inflammation tips at 3 days and then starts going down by 5 days. Now you are telling us a delay of 3 days. So you need to explain that to us. Just a comment on preventive measures on burns and the person who presented on burns. As Dr. Fraha said, one of the preventive methods is if we convince the community that epilepsy is a symptom, or for many other reasons. One of them is to know what's causing the epilepsy, to see if it's secondary or primary, and then adherence to the medication they are given, because they take it, and if it doesn't come for 1 month, they stop it. Then they come into status epilepticus. For example, now I have a patient who is in ICU because stopped medications, and if you fail on, I think that's when you get deep burns, because they fall on whatever is burning them and they keep there. So adherence to medication is very important. Thank you.
Proceed as follows. I want Dr. Allen to answer to the questions, the question of Prof. Faustin. It's only the one question addressed to Allen. Then we proceed with Olivier, because almost all questions are addressed to Olivier.
Thank you very much for the questions, and thank you for the presenters. Actually, it was amazing to have all of these topics discussed here. For the question addressed to me about the global mortality in emergency abdominal surgeries, actually that study was also done here in Rwanda, included the CHK, Rwanda Military Hospital and the Bushenge Hospital at the time that we did the data. As you have seen, the mortality, it's almost about 4.6%, especially when you go to low and middle income countries. And it's not so far from the local studies that we are having here. So starting by by your study that you did for your thesis, and also other studies like the one that done by Christophe Mirimbanyi and the colleagues, and another one published by Twahirwa recently in the beginning of this year. The mortality rate, apart that they are just comparing the emergencies done during the day and during the night, by the mortality rate was ranging between 3.6 and 6%. So I can say that we are not so far from the global mortality that we have in low and middle income countries. Probably another study that I have found here in Rwanda is the one published recently, where they were saying that the mortality rate was about like 2.8. Probably meaning this recent one that we have. Probably meaning that we are really improving well, going to from the low income countries to the middle ones. Another important thing was that the checklist was really very associated with decrease in mortality. So probably if we will be implementing the checklist in our hospitals, in the abdominal surgeries and other surgeries extrapolated, we shall just calm down and decrease this kind of mortality. So it's what I can say. Thank you. Olivier is going to respond. I probably will help him.
Thank you so much. I've got almost 3 questions. 2 questions and 1 comment. So about the question of Provost of the cost, ankle brace versus backstrap. Obviously they are different. The ankle brace is pre-manufactured, so it's more expensive compared to backstrap, almost twice. And this is one of the challenges we got, because some patients were not recruited since they were not able to afford that treatment. But among our recommendations, we recommended maybe hospitals to avail them, or even insurances. It's not that much expensive, but obviously it is expensive compared to backstrap, but it is effective while comparing with the backstrap. So the next question was about why didn't I include the forecast. So among the previous reported studies, they recommended using backstrap and maybe boots and ankle brace. So the reason why the forecast is not recommended is that after an ankle brace or an acute ankle injury, there is edema, there is swelling. Once you apply forecast, and the edema resolve, the forecast will be loose. Or you may apply it and the patient may end up with compartment syndrome. That is one of the reasons. But the other reasons is that it has not previously been reported. So the comment of Dr. Vikorotti, so the ankle brace, the grade 2 and 3 acute lateral ankle sprain are fairly treated the same way. The treatment is the same, even the duration of the treatment is the same. So the difference is about the classification, the West Point classification. Grade 2 is it's kind of partial ligamentous tear, while for grade 4 it is complete. But in the literature, the treatment is almost the same. But this also came in my mind, and that's why I recommended to conduct maybe later a semi-blinded randomized control trial. Thank you so much.
Thank you for the question. So you asked if we have to wait if that the inflammation is resolved or swelling. The literature says that to be accurate in treating maxillofacial surgery, you have to treat it below 3 days. It is all fractures have to be fixed so that it cannot worsen the condition, because suppose that if we have mandibular fractures, the mandible is the moving bone. So if we left it for inflammation to be resolved, it can cause sliding the bone on the bone, and which we can lead to infection. And also in the management of maxillofacial and mandibular fracture, there is 3 types. It can be conservative, can be ORIF, also MMF, maxillomandibular fixation. So those management, ORIF and the MMF, have to be done in 3 days to be accurate, so that the patient will not have infection, malocclusion, malunion, and so on. So it's like in orthopedics. Orthopedics also, even if they don't put a full cast, but they put baxilla so for mobilization of the bone, and they make this alignment. So this is what they say, literature is saying. Thank you.
So I wanted to compliment Alan for the question he was asked. In these collaborative studies, I think there is a room also, as you can extract data based on country level. I think you can also extract data from country or even hospital, and then compare them with the local ones we have been conducting or have been conducted for better decision making. Thank you.
No, I have a question, 2 questions sent by YouTube. So one is about the checklist, and is asked by Prof. Dhruvan, I think is from India. So is asking the presenter and saying, have you tried to modify the safety checklist in your setting rather than using the generic checklist to improve compliance?
We didn't yet use the check our the article I used to present here was the only one we have available, done by Global Surgery. But
okay, thank you very much. Actually, the checklist one was initiated even here in Rwanda. I remember 2010, 2011. We discussed a lot about the generic one which was being used. Prof. Austin was there and the colleagues, Vikorota and Vaisen, who were in resident at that time. We discussed a lot about the one who is used widely, and we tried to design the one in collaboration with the University of Virginia, the one that we are having in our theaters in CHK, and it was even the one which was populated through the Ministry of Health, being used all over around the country. So we discussed about the component of what can be captured in our settings. So it's really adapted in our settings. And really the study, there have been other studies, not only this one. Even the WHO checklist, the microstudy that we are doing with the preliminary result right now, the compliance was not really due to the adaptability of this checklist, but it was, we have seen that was associated rather than on the training of the one who is initiating the checklist. If you are having a senior nurse with a junior one, the senior nurse was willing to start with the checklist. And another reason that the surgeons were saying was it takes time. I think we need really to move forward and understand that the checklist saves the life. Thank you.
So another question by YouTube is addressed to Blaise. It says, nice presentations. Blaise, should you make it a movement against PBC. PBC, I don't know what it is.
Post-ban contractures.
Yes, is asking if you should make it a movement against PBC.
Thank you. It depends on the classification. So in case, for example, according to the classification we have used, which is morphological African skull contracture classification algorithm. So it depends on the classification. For example, the patient who is in class A, the contracture doesn't, the contracture prevent mild range of movement. While the patient who is in class D, the contracture restrict the range of movement with severity. Thank you.
Okay. It was a nice session, long, but with some inconveniences, but it was very nice. Thank you for all presenters. Thank you for. So before we move to the next session, we have Prof. Morton from Birmingham, and I let the MC introduce him once his presentation is ready.
Thank you, Dr. Isayin Chogoza and Ms. Esperance Mohayonayo for chairing well this session on about the emergency surgery. We are going to now welcome Prof. John Morton, who is going to have a time on global surgery collaborative. And Dr. John Morton is a leading colorectal surgeon at the University of Birmingham and has been a professor of surgery since 2006, and he's the Barling Chair Surgery at the University of Birmingham from 2015. And he has been the Director of Clinical Research at the Royal College of Surgeons since 2011. He has been leading multiple research and randomized control trials for the practice in surgery. And he is currently the pioneer for collaborative research in surgery, and he's the director of NIHR Research Hub in Global Surgery. So if his presentation is ready, we're likely to warmly welcome Prof. John Morton. As they're getting the presentation ready, we'd like to welcome the second session presenters that will be chaired by Dr. Alan Ingabire to have the presentations ready to give them to the IT team, and to remember that you're going to use the computer on the desk, and to not switch it off. You should keep it open, because once you switch it off, it delays the next presenter to get ready. And if you see me standing with my computer, I'll be giving you a small hint on the time you are left with, so that you can respect our time. Thank you.
Oh, man.
Apologies once again for the inconveniences. The next speaker is not available right now. We are going to shift to another time. So we're going to welcome the second session. And the second session will be chaired by Dr. Alan Ngawire on surgical site infection. And as a bio for Dr. Ngawire Allen, he's surgeon, fellow in orthopedic from COSEXA, and a PhD candidate at the University of Rwanda, and he's a consultant in orthopedic unit. And he's the deputy director of NIHR Research Hub and Global Surgery in Rwanda. He has a public health also master's from KIU and a certificate in Geneva on master education. He also is a lecturer from the University of Rwanda since 2015, and he has more than 20 papers, peer-reviewed articles. So I welcome Dr. Allen to chair this session.
Thank you very much, Dr. Chris. When we were working together, she was talking and I was asking myself if it was about me. So this session is about surgical site infection. We'll be having 6 presenters. We are going to start right now. I'm going to apologize for you. We'll be starting by lecture already is there. I was going to start by the 6th one, but she's there. Okay. Lecturers from the University of Birmingham, the senior trial manager. We have been working together for almost now is 6 years. She's really good at the clinical trials, and all the time when we were facing problems and concerns, she was ready to solve this. Can you have the computer ready for her? She's going to talk about the Falcon. It's the first trial, clinical trial that we have done here in Rwanda, and this trial has been a success. We're comparing the chlorhexidine and the iodine with a kind of sutures. So, there is a microphone there. No, let me give you this one. You are welcome.
Thank you, Alan. Thank you very much. It's a delight to be here today, everyone, to speak to you about the Falcon trial. I think my slides will be displayed in just a second. So just to give you a bit of background about me, so I'm Rachel Lillywhite. I'm Trials Management Team Leader at Birmingham Clinical Trials Unit. As Alan mentioned, I've been working with the unit now for about 4 years and was involved heavily with the first trial, the first randomized controlled trial in the portfolio, which was called Falcon. We'll just wait for the slides to load. So as we've discussed quite a lot already today, surgical site infection was prioritised as one of the big pressing needs with the annual prioritisation cycles, both in Johannesburg and in Rwanda 2018. So Falcon was essentially the first of these studies, looking at triclosan-coated sutures and skin preparation solution. To determine whether or not we could reduce the incidence of surgical site infection. And obviously the portfolio of studies that we've developed, most of which run in a very similar theme. So we have lots and lots of surgical site infection studies within our portfolio. Perhaps I can just start without the slides. So essentially the rationale for prioritising these as sort of urgent clinical needs was that alcoholic chlorhexidine and triclosan sutures had been recommended by the WHO and by NICE in the UK to essentially, the guidelines essentially were designed to mitigate against surgical site infection. However, the data on which they were based was generally of very low quality, and there was little and nothing from the global south. So we felt that there was a fairly significant unmet need there, and an evidence gap that we would like to fill by way of the trials that we've developed. So the skin preparation that we were using was alcoholic chlorhexidine, as I've mentioned, and the comparator was 10% povidone iodine. The sutures were triclosan-coated sutures versus non-coated sutures. And the reason for deciding upon these interventions really was the fact that they were so ubiquitous around the world. So obviously they're very low-cost interventions by comparison with alcoholic chlorhexidine and triclosan sutures, but also they're very low cost and freely available. So it's something that, you know, essentially could be used anywhere around the world. So the randomization was performed 1 to 1 to 1 to 1. So there were 4 arms in the trial with equal numbers of patients going into them, and it was stratified. So it was a functional trial design, essentially a factorial trial design. The intent of this was to make sure that we were able to recruit patients in the clean contaminated stratum and to those which had contaminated and dirty surgeries. And the idea of this is essentially running 2 trials in one. So we know that there will be differential event rates within these populations, but we wanted to include all of them because we felt it was important that we included patients from lots of different populations to make this really as generalisable a study as we possibly could. So patients were recruited from hubs and spokes, and as we've mentioned previously, this is the model that we use within global surgery. So you essentially have a hub organisation in each country which oversees the spoke network, so they're responsible for setting up, training, making sure that spokes are properly resourced, and that the trial is running appropriately across the whole network within the whole country. Adults and children were recruited to the trial. Quite interesting that essentially the child lower age of eligibility was decided by country, so each hub director chose the appropriate lower age of eligibility in their country, obviously according to ethical guidelines and local acceptability as well. So some of the youngest patients to go into this trial were approximately 6 months old. Patients receiving any surgery with any abdominal incision of 5 centimetres or greater would be eligible to the trial. And patients in both emergency and elective settings were eligible, and that included at the start of the trial caesarean sections. So the primary outcome for the trial was surgical site infection at 30 days. Again, this is a common theme. You'll see this running throughout a lot of our trials. It was determined using the Centre for Disease Control definition of superficial or deep incisional SSI. Okay, so the surgeon and theatre team were unblinded because we felt that it wouldn't be possible really to blind the theatre team. Obviously, some of the interventions that we're using are quite distinctive, iodine, for example. So we blinded instead the outcome assessors and patients, and we felt that this would improve the trial's integrity. So just briefly onto the statistics side of things. So the sample size was 5,480, and you've got different levels of recruitment in each of the stratum there, essentially, as I've mentioned, because we expected there to be a differential event rate between the two different stratum. The planned subgroup analyses were urgency, age, missing data, and checklist completion. So you'll see we over-recruited. We recruited to 5,788 patients in total from 54 hospitals and in 7 countries. And you can see here the split. So 3,091 patients were recruited in the clean contaminated stratum, 2,697 in the contaminated and dirty. 86% of those were adults, 14% were children. We were quite impressed by this, actually. We were quite glad to see that there had been a fairly significant number of children included in the trial. 67% of these were emergencies. Again, we were quite impressed by this because obviously the pathway for recruiting emergencies, especially in a trial such as this where you need to have upfront consent prior to surgery, is a little bit more complicated. And 49% of those were midline incisions. So this really is perhaps more of a question than a kind of thing to present to you. So this is to look at the comparison to your general clinical practice. One of the things that we thought was quite interesting on this slide was the WHO checklist usage was 86 to 88%, which we thought was quite high at this point. Pulse oximetry 96 to 98%. Antibiotics 90 to 95%, and a bit lower temperature monitoring 28 to 30, and blood sugar monitoring at 9 to 10. So I guess the question there is really, how does this compare with your general clinical practice? So onto the results. So 22% of the cases had surgical site infections, 15.5% from the clean contaminated stratum and 30% from the contaminated and dirty. And a disclaimer here, I'm not a statistician, so I'm not going to go into too much detail on these slides, but this is the overall event rate, essentially, and this shows that overall there is no statistically significant benefit of either intervention, chlorhexidine, or the triclosan-coated sutures compared to the comparators. And this breaks it down. Adjustments have been made for minimisation factors, so age, urgency, hospital, which was a random effect, and interventions. And again, not a statistically significant difference between control and interventions in either stratum. And this is just the secondary outcome, so reoperation and 30-day mortality. And just to run through the conclusions briefly, so as I've said, there's no evidence supporting 2% alcoholic chlorhexidine usage or triclosan sutures that we have found. With that said, I think it's really important to note here that although the trial is what we would refer to as a negative trial, the results will have a positive impact from this trial. So we have filled an evidence gap which was previously completely unmet. So we have built that evidence base, and with that evidence base we can go to bodies such as the WHO and say that actually these more expensive interventions are not improving the outcome for patients. And this was a high quality, pragmatic, well reported trial, so there should really be no questions as to the data integrity. Obviously, as I've mentioned, changing global practice is required. And also interesting to note that high SSI rates still predominate. So this is still a very relevant, pressing question that we feel these kind of SSI studies that we've developed in the portfolio will help to meet. And And just my final two slides, which actually refer back to comments that Forstin and your principal have made. So the impact of the study, I think it's really important to reflect upon the impact. The Lancet publication for this study was published in 2021 in October. We employed a corporate authorship model, so all authors were listed, all investigators were listed as authors. This particular publication, it had an editorial associated with it from Richard Horton, and it was the featured article for Lancet Week in November of the same year. Since then, there's been a Lancet Infectious Disease meta-analysis published, which essentially updated the quality assessment for SSI trials and demonstrated practice-changing findings in light of the Falcon data. That was published in May this year. In terms of general training and the impact that the trial has had in relation to that, 238 CPD certificate hours have been awarded from the Falcon Think Surgery module, and I've included the link to the Think Surgery module so we can distribute these slides after the meeting if you would like to complete it if you haven't already. It's also been presented at national network meetings in India, Nigeria, Rwanda, Ghana and Benin. So just my final slide here is an alt metric. So if you're familiar with this website, essentially it looks at kind of categorizing different ways in which publications have had impact. And the most important one, I think, was the fact that Altmetric has tracked 21.5 million research outputs across all sources so far. And among all of those, the Falcon paper that was published in the Lancet was in the top 5%. So this is a really high impact finding and publication, and it's only been deliverable with all of your help and support, and the help and support of your communities and the patients that have been participating in this trial. So that's the end of my presentation. So I'll just finish there. We'll take questions at the end, won't we?
Thank you very much, Rachel. You will have a seat and you will wait a little bit for the panel discussion. Actually it was a good talk, I think. We shall just have a discussion about that. So I'm calling upon for the next presenter, who is Alphonsine Imanishini, who is going to present on feasibility and the diagnostic accuracy of a telephone wound hearing questionnaire in the detection of surgical site infection following abdominal surgery. This is a study in a trial in 7 low and middle-income country. This has been populated from the Falcon that has presented, but also from Cheetah that we are going to listen to. Alphonsine Manishino is a research nurse within the Rwandan hub, and she's going to take you through this presentation through the following 10 minutes. You are welcome, Alphonsine.
Thank you, Dr. Alvin. As he had been said, I'm Alphonsine Manishini. I have working with Global Surge since 2019 in the capacity of research nurse. So I'm glad to be here presenting the feasibility study conducted in Rwanda and different countries around the world. So it is stand for TARON, which means feasibility and diagnostic accuracy of telephone administration of an adopted patient-reported wound hearing questionnaire for assessment of surgical site infection following abdominal surgery in low and middle-income countries. As we all know, a few years ago, it was not easy to find someone with a mobile phone, but nowadays things have been changed. So this study was about seeing if we can try to follow our patient after abdominal surgery and do the follow-up, the 30-day follow-up using a wound hearing questionnaire. So surgery has now become a global priority in our days, and we need to do more randomized trials for the safety of our patient, and also to see how we can decrease the impact of SSI, especially in low middle income countries. If we take an example for Rwanda, for example, a patient from rural Rwanda, to return for follow-up, most of them, there are some who have to work for 12 hours. They will suffer loss of earnings and wait, a busy clinic waiting. So it is really important to see what we can do to try to help our patient. So everyone can ask him or herself, then what will be the solution? Reason why we tried to conduct a TARON, which is a SWOT methodology. It was a study using a SWOT methodology, which means a study within a clinical trial. So it was, first of all, used in UK, where they conduct a blueberry study to see if this questionnaire can be understandable if we try to call the patient. And this study demonstrates that there is a high sensitivity in using this questionnaire while we are calling patients. So this questionnaire was focused on the guideline for prevention of SSI developed by the CDC, following all the criteria to identify SSI. So, as I was said, the method was a SWOT methodology within Falcon trial, Cheetah and Penguin. So, but now we are focusing on Falcon because this have been conducted here in Rwanda. So, first of all, as I said, the questionnaire was translated in different languages in country which participated in the trial. In Rwanda, we participated also, and as it has been said by Rachel, the main patient was recruited during Falcon study, and 7 countries from the global surgery participated in this study, and around 1,196 participants were recruited in all those 7 countries to be participating in TARON. So here is the trial follow-up. So patients were recruited in Falcon, then the telephone wound healing questionnaire was administered at between 27 and 30 days. And then at the 30 days, the patient was advised to come to the clinic so that the clinician would assess if the patient has the SSI. So if you go to the results, this study shows that there is really a high sensitivity, as I said, and specificity in the diagnosis of SSI. So reason why, if we see about the recommendation, one will be trying to use this wound healing questionnaire in assessing our patient. And the other thing I can say is that even all the studies we are conducting on global surge, we are trying to follow up patients at day 30 without coming back to the hospitals, where we call them and they describe their health status. So, so the discussion shows that the diagnostic accuracy for wound healing questionnaire is good, and the tool is now available for global implementation in post-operative surveillance pathway. In conclusion, this study confirms that digital follow-up pathway in low-resource income countries are feasible, and if we try to use our telephone, as it have said, the 50% additional patients were able to be followed, and if we support the estimate of high access to mobile communication as it is recommended by World Bank, I think we will be much more and try to help our patient in terms of follow-up. So thank you very much.
Thank you very much, Alphonsine. We will have a painful discussion, but now Talon also is a good one. To call a patient from Chibogor to Nyamasheke to come here for only assessing probably was a hernia repair and a wound already healed. So we shall have a discussion about that. I think we are moving forward. I'm going to call upon Donna Smith from Birmingham as a clinical trial manager, senior clinical trial manager. That we have worked together within CHITA, and she's going to talk about the cluster randomized trial, history growth and instrument change at the time of wound correlate to reduce surgical site infection in low and middle income country. I think this study has taken place within almost 13 hospitals, so many of you know exactly what we are talking about. And don't fear, Kita is not here. It's only in the mnemonic that we are using. Donna, you are the most welcome.
Apologies. So the results are at the moment just strictly confidential, and that's because we haven't published the data yet. We're hoping to submit to the Lancet any day now, but at the moment we haven't shared those results, so they need to stay within this room, if that's okay with everybody. So CHITA was the first cluster randomised trial from the surgical unit. And it's looking at a change of gloves and instrument change prior to wound closure in the hope that we can reduce surgical site infection. So just some background, there are no clinical recommendations, as I'm sure you know, from the WHO or from the Global Surgery Unit as yet.
So we are going to hand a little bit to MC. We are going to welcome Prof. Norton and the other three presenters. They will just come after Prof. Norton has spoken. I think you can begin your places and then you listen to Prof. Norton and later on we will just come back. We are sorry for disturbing. And this session was the gender balance. I think it's the only one which is balanced. So that's really very, very interesting. We are going to listen to Prof. Norton and then coming back after his talk. Thank you.
Sostine, can you hear me?
Yes, you can hear you, Prof. We can hear you. You are the most welcome to this session. We are muted, Prof.
I can't hear the main room. I don't know if you can hear me, Boston.
Yes, we do hear you, Prof. Please go on.
I can't hear you, Boston.
So we are hearing you, so you have the floor to go on and give.
Okay, I'll try and put my slides up. Is that what you'd like? Can you see my slides? Hello?
Yes, we see them.
Excellent. And you can hear me?
Yes, we do hear you.
Okay. Would you like me to start talking?
Yes, after closing the door, yes.
Excellent. And you can see the slides. Okay, look, it's lovely to join you in Rwanda. I'm going to close off my video camera. For those of you who haven't met, I look forward to meeting you soon in the future. I'm sorry I can't be with you in Rwanda today, but like many of you, I was operating, so I couldn't join but it's lovely to join you by video conference. And it is a huge pleasure for me to present to you on the Global Surgery Unit, which is I'm part of, and I'm hugely proud to be part of the Global Surgery Unit. I will turn off my camera just so that the slide sharing works, I hope, better. So, the Global Surgery Unit has been in existence for some 6 years, and it has been a huge success. And the success of the unit has been due to the leaders of the unit. The leaders of the unit are the hub directors, and it's of course the meeting today is being held by Dr. Faustin, as you see here from Rwanda. We also have leaders in Benin, Mexico. One in Central Africa, which of course is yourselves in Rwanda, and we're hugely privileged to work with you. Thank you. The network in Rwanda has been hugely successful, has been per capita probably our most successful hub. So congratulations to all of the hub, to the hub director and all of the principal investigators at each of the 12 collaborating hospitals, which covers the whole country of Rwanda. We're very proud to have a national surgical network. The vision of the unit is that we need to provide high quality evidence to support surgical change in practice, to promote collaboration between surgeons, not just across the country, but internationally across continents. And ultimately, we want that to lead to patient benefit. Each year, we have a prioritization meeting, and the last one was in Ghana, and you can see the photograph of all the attendees here. I should have picked it. There's Faustin there. I can see you, Faustin. I know that there's others there. I can't quite make out JC at the moment, but it was a great meeting. And at this meeting, we decide what the important and key parts of the program need to be developed and what research is required to be done. Very important that you understand that all of the publications from the Global Surgery Unit are published under a corporate title, which might be Global Surge or the Global Surgery Unit. And that means that all of the collaborators in the study are named authors on the paper. So all of the investigators are included in the publication, because without the investigators, we would not be able to carry out the work that we do together. You are now part of the largest medical research network in the world. That was recognized by the Guinness Book of Records earlier this year with the COVID Surge Week collaboration, which was run through the unit by all of the collaborators. But this has been going on for years. We started, of course, with the Global Surge Network, where we worked across 100 countries, and we looked at wound infection and improving outcomes from surgical emergencies. More recently, the COVID surge work has allowed us to quickly highlight the huge mortality from operating on patients with COVID and the high risk of major pulmonary complications. And that helped to change and guide practice across the world. That same study has also been used to look at the impact of COVID on surgical procedures, and has shown a massive backlog of operations, some millions of operations that have been postponed over the last 2 years. And this is going to be a huge burden to carry. Foster, I'm just getting a little bit of feedback. I hope you can still hear me. On top of these huge cohort studies, we also run very important interventional studies. The first study that we ran together was the Falcon trial. In this trial, we investigated the use of alcoholic chlorhexidine and triclosan coated sutures to see if they benefited patients from reduced wound infections, because they were recommended by the WHO. This study recruited over 1,000 patients a month, and in the end recruited nearly 6,000 patients across 3 continents. And that paper, your work, was published in the Lancet 8 months ago, and you'll see it was published under a banner, the NIHR Global Research Health Unit, and all of the collaborators were included in this publication as co-authors. And this, if we look at the patients who were recruited to this, the network in Rwanda was absolutely central to the success of this study, and without you, it couldn't have been performed. And as I say, I think that per capita, there were more patients recruited in Rwanda than any other country in the world. That is a great credit to your network and your surgeons and your patients and collaborators. But Falcon is just the first study. The next study that we're already running, and you have played a huge part in, there are at least 12 centers in Rwanda who are part of the Cheetah trial. All of the 12 centers have randomized patients, except the difference in the Cheetah trial is that instead of the patients being randomized, we randomized the hospitals. So hospitals were either randomized to receive the intervention or to continue with routine practice. And the intervention was to change your gloves and instruments at the time of closing the wound in contaminated and dirty surgery. And each hospital entered about 200 patients into this study. And I'm delighted to tell you that over 12,500 patients are now entered into Cheetah. And that study has closed. And the results of Cheetah will be circulated to you in the next few weeks. It is a very exciting study, and it is going to change practice across the world. And the Rwanda network, again, was absolutely central to the success of this study. So from all of the collaborators in the unit, we thank you. So the Falcon study is completed, the Cheetah study is completed. The Cheetah study will be published, I'm sure, in the Lancet at the end of this year. The Penguin study, which is a study of high-dose oxygen and of oral mouthwash with chlorhexidine before surgery. The Penguin study has recruited the first 2,500 patients and is now finishing its pilot phase. The next study to open is, of course, Protect Surge. And this is the study that you are now launching in Rwanda. And I would just emphasize to you that you are the first country to set up Protect Surge. You are the first country to investigate using nitric oxide inhalers to reduce post-operative pulmonary complications, both from COVID and not from COVID. So we're very excited to work with you. And I would just ask everyone in the network, please, would you remember that we are all going to learn across the world from you. So share your experience, we will learn together, and you can show the rest of the world how to run this trial. There are many other trials. Crane, Eagle, and Tiger are all opening or at various stages of completion, and we have new studies in the pipeline. So it's a very exciting collaboration, and we're delighted to work with the network in Rwanda. So finally, It is my pleasure to work with you and collaborate with you as part of the Global Surgery Unit and to be part of the largest clinical research network in the world is a huge privilege for all of us. And I trust we will be working together for many years to come. Thank you, Faustin, and thank you to all of your collaborators in Rwanda. I'll stop there.
Thank you, Prof. That was really very helpful, and thank you for making the time to join us today. We know how busy you are, and thank you really for coming. Can please people mute their mics?
I'm muted. I'll mute.
Yes. So I was saying that we thank you for making the time to join us today. It's a huge privilege to have you online. So we know you are so busy and you are running from the theater and you are going back there. So, but before we leave us, is there any question from the audience that will be addressed to Prof. Morton before he leaves? So apparently there is not. We thank you, Prof, for joining us today, and we look forward to have you anytime we call you upon as you do always. Thank you very much.
Thank you very much. I was expecting to have more questions about the talk, but it means that we have understood everything. As we are moving forward, can you introduce the Rwanda FDA? Yes, yeah. Okay. As we are moving forward, I think the MC is going to take us about the little bit of the change on the program.
Right, thank you very much. You are going to apologize. Are we going to stand because I've seen people are yawning, others are sleeping, others are having a very low blood sugar. So I don't know what we're going to do, but we're going to be patient a little bit. We had to switch a little bit programs because of what has happened. So if you can kindly stand so we stretch a little bit. We can tell blood sugar, come back please. While we are going to sit for a small time. The one who are mostly sleeping are the one who are seated. So yes, so very welcome. Thank you once again. So, and as we're going to switch a little bit while we're still doing the second session, we're going to have a small talk on Rwanda FDA, which is going to give us a talk on the clinical trial regulation. And after that, we're going to resume back our second session. And the FDA clinical trial regulation presented by Dr. Alphonse Dayambage, who is a consultant physician specializing in medicine at the University of Rwanda. He earned a Bachelor of Medicine from the University of Algeria, and he is working as an analyst in the clinical trials at the Rwanda FDA, where he is now responsible for key issues related to the Rwanda clinical trial legislation, implementation of good clinical practice, and also including the risk assessment and clinical trial monitoring. You're welcome, Dr. Alphonse Dayambage.
Thank you for the introduction. Dr. Alphonse Ndayambaje, here representing the Division Manager of Pharmacovigilance Safety Monitoring and within Rwanda FDA, dear Prof. Foster, and the representative from Global Surgery Research Hub Rwanda, dear representative from University of Birmingham, dear hospital directors, head of department, colleague researchers, doctors, trainees, and students, good afternoon. On behalf of Rwanda FDA, I extend my thanks to this opportunity to engage with such wonderful, enthusiastic audience that want to learn, implement clinical trials, making Rwanda a research hub and home for clinical trials in Africa. Thank you. I extend my gratitude to Global Surgery Research Hub Rwanda as one of key stakeholders in the clinical trial for their commitment, professionalism in implementing clinical trials with the highest standard. Now, we are going to talk about the state of play and the regulatory framework for clinical trials in Rwanda. To start, the WHO global benchmarking tool that incorporates the concept of maturity levels and evaluates the regulatory system of medical products include also many functions than regulation of clinical trial falls under the responsibility of national regulatory authorities. For this, Rwanda FDA was established by the law of 9th February 2018, and especially in its Article 8, where the authority has the mandate to regulate, inspect clinical trials, regulate the use of unregistered product regulated under this law, and also for the use of, for the clinical trial purpose, and also compassionate use. Also, it has the mandate to advise the government on matters related to this law. Rwanda FDA has many legal instruments and also conduct enforcement on implementation of clinical trial through the provision of the regulation governing the conduct of clinical trials in Rwanda, especially in Article 7, where any clinical trial requires pre-authorization from the authority before being implemented in Rwanda. And also the authority conduct the assessment of the application, namely the protocol and other regulatory requirements for approval, and also their post-approval activities that falls under provision of the law, the regulation, Article 30 and 24, where the sponsor or the principal investigators and research team have to monitor and report any serious adverse events or suspected and expected serious adverse reaction occurring to any trial participants, and also the authority have to inspect the compliance on good clinical practices and regulatory requirements, and also make any required regulatory decision. We have also the regulation for regulatory services, tariff fee, and fines. The authority also has many other instruments to conduct enforcement on clinical trial, namely the guidelines for clinical trial application, where you have the requirement for clinical trial application in normal circumstances, in public health emergency like COVID-19 we have, and also other regulatory requirements for approval of amendment for authorized clinical trials. This is where we have received the application, pre-application for Protect SAG, and later on, looking at the dynamics in management of COVID, they have received an approval for amendment and use of a new investigational product. We have also the guidelines on reliance, where the authority may adopt decisions from other national regulatory authorities and regional and international bodies to implement any regulatory decision. And currently we have many MOUs with regional regulatory authorities, especially Ghana FDA and also Tanzania Medical and Drug Authorities that also has reached the maturity level 3. We have also the guidelines for good clinical practice, and as you know, the GSP principles take their origin in World Medical Association Declaration of Helsinki, and they are international standards for the design, conduct, monitoring, recording, analyzing, and reporting in clinical trials. And this provides the assurance that the rights, the integrity, confidentiality of trial participants are protected, and also the results from the trials are accurate and also credible. We have also instruments and provision from the guidelines for review and approval of clinical trial application in Rwanda, and this after receiving clinical trial application, there are processes for assessing the protocol and other regulatory requirements, and also this will allow the authority to issue the approval or in deemed necessary, and also reject the application. After the approval, the authority conducts clinical trial inspection, good clinical trial inspection, where we have to oversee whether the implemented clinical trials are compliant to the GCP principles and also regulatory requirements for the safety and the well-being of the trial participant, and also for the validity of the trial results. Allow me to talk a little bit on the clinical trial application review and approval process. It is our daily responsibility to receive a clinical trial application. We normally receive the application from the sponsor for clinical trials of the principal investigators or other designed personnel. And also among our requirements, we need to receive the ethical clearance from the Rwanda National Ethics Committee, and the Rwanda Food and Drug Authority won't issue any approval once the application failed to receive the ethical clearance. And in some circumstances regarding a public health program like tuberculosis, HIV, mental health, and other program, we may require a collaborative note from the Rwanda Biomedical Center. And once the application is submitted to authority, we conduct the assessment for compliance to the regulatory requirements, and also we evaluate the scientific validity for the protocol, and we may raise additional queries or clarification that will be sent back to the applicant. But once the applicant has outstandingly responded to all clarification, the approval is issued. And this has to be all processed within 60 working days. But we have our FIFO rule, and the first who apply is the first who is served. And also we have also to have these timelines. Once we submit the query to the applicant, we stop counting until he submits the responses, and then we can move on. We have about 29 application requirements, but they are critical depending on the design of the trial, the quality of the investigation product, the design or the implementation phase with regard to the experience of the research team, and also other relevant regulatory requirements, like the study will be implemented at a site where recruitment may succeed. And once we receive all these application requirements, the review will focus on the submitted application requirements, and also from there the approval may be issued. According to the provision of the regulation, the clinical trial oversight unit within the pharmacovigilance and safety monitoring at Rwanda FDA conducts post-approval activities. And also on the side of the investigators, they receive and they have to submit safety reports, monitor the serious adverse events and any suspected unexpected serious adverse reaction, and all this has to be submitted to the authority within prescribed timelines, not later than 7 days for upon noticing the event, but also a follow-up report has been submitted within further 80 days. And also they have to submit clinical trial implementation report, namely progress report, site closeout report, and final report. This allows the authority for analysis and also appraise the outcomes of the study. We usually conduct the inspection at trial site for compliance, to monitor the compliance on GCP principles and regulatory requirements, and we have different type of inspection. We conduct a routine inspection, that's we notify the principal investigator, and we agreed on the time of inspection, and also we ask him to avail all the essential documents pertaining the conduct of trial that will be reviewed during the inspection. And from the report, the deficiencies that has been found, we may conduct a follow-up inspection to see whether the corrective and preventive action from the research team were adequately implemented. In some cases, we may conduct a for-cause or investigative inspection while we have information about the procedures that may jeopardize the safety of the participants, also the validity of the outcomes from the study, and also we conduct the kind of joint inspection involving Rwanda FDA clinical trial staff and the Rwanda National Ethics Committee to oversee the overall compliance to GCP principles and also the safety of the trial participants. From the report of inspection, the authority may apply some of the regulatory actions mainly administrative, like issuing warning letter on a given major findings, and when it comes into force, we may temporarily suspend the trial or withhold the authorization, and also permanently terminate the trial. And we didn't have experienced this situation, but deemed necessary, we may file a case to the police or RIB once there was any event that may pertain to crime. Let me go through a recent update on the clinical trial data. From the past 3 years, we have received about 28 applications, but the majority of them, about 50% of them, were received within last year, during the last year, and have granted 21 approval. Among them, we have the 3 trials from Global Research, Global Surgery Research Hub, Rwanda, the Falcon. We have received the notification, and we have also regulated Falcon, Cheetah, and recently we have approved the Protect SAG. And we have conducted GSP inspection, and we were amazed to have to notice that this trial were conducted with the highest standards. There was no objection, and I thank you for your commitment. And from there, I commend the Global Surgery Research Hub and the Birmingham University, and we renew our commitment and want them to bring more application and make Rwanda a home for clinical trials. And my final note is to thank you for having this audience to inspire the younger generation, not only implementing operational research, but also it is possible to conduct clinical trials that transform the lives of our community and also the scientific community. Thank you very much.
Thank you, Dr. Ndayambaje, for the good recommendation and reminding us about doing the right thing once it comes to clinical trials. I hope we'll not reach for the time of RIB and police to come and arrest us in case we didn't do the clinical trials appropriately. So I think the people have talked. People are exhausted, and people are truly exhausted, and it will be hard to have the 3 last sessions to be continued. So we are going to have a small, only group photo here. Then the questions will come at the end, together with all the 6 topics. So we're going to have a group photo session here. Then we're going to have our lunch at Agaciro Hall. Agaciro Hall is just above the swimming pool, the main restaurant. So please come forward, and we're going to have only 30 minutes of lunch. So we expect everyone to be back here by 2:30. Please, please, please. And if I please raise my computer on you, and the time is running and you don't respect it, I'm going to come up and take the computer with you. Please, I beg you, so that you respect time. I see Chai backbenchers were sleeping. Now they don't want group photos. They don't want to eat. So what do you want, backbenchers? Backbenchers, I have a very big problem with you. So can backbenchers go up? The ones who just came, Dr. Hirwa, up. You can go up. You can go above and have a good photo session. We don't all need to be here. You can have a group coming up. See you all at 2:30.
were still having the symptoms on the day of surgery. So as a result, among those patients who have been included in this study, a pre-operative ACE-ESD diagnosis at just a 30-day mortality rate in a patient without ACE-COVID-2 infection was 1.5%. While in a patient with a preoperative ACE-COVID-2 infection diagnosis, mortality was increased in a patient having surgery within 0 to 2 weeks, 3 to 4 weeks, and 5 to 4 weeks. So coming back to the surgery that was performed while the patient was like beyond of 7 weeks after being infected, diagnosis was associated with a similar mortality risk baseline. This means that the mortality rate was equaling to the patient that who had a preoperative ACE-COVID-2 infections. After 7 weeks, if patient were operated after 7 weeks, it was demonstrated that the risk of mortality was decreased. So as a discussion, there was no many study done about this phenomena, and there are some studies that have been conducted, and they demonstrated that the greater granularity in this analysis compared with previous study has enabled more than 7 weeks to be determined as the optimal cutoff. So as a strength, this study was globally and high data completeness and rapid study delivery, but some limitation were due to some patients maybe were not detected about this condition, and we were not able to measure the length of stay. That was unknown. As a conclusion, and as you can see, we found that the risk of postoperative morbidity and mortality are greatest if patient operated within 6 weeks of diagnosis of ACE-COVID-2 infection. Our result suggested that where possible, surgery should be delayed for at least 7 weeks following ACE-COVID-2 infection. Patients with ongoing symptoms which go beyond 7 weeks from diagnosis may benefit from further delay. So as recommendation, where possible, delay surgery for at least more than 7 weeks, and the patient with ongoing symptoms above 7 weeks from diagnosis may benefit from further delays. This was our recommendation. I thank you for your kind attention.
Thank you very much, Emmanuel, for the great presentation. You can have a seat waiting for others for discussion. So, you see, this is a really also huge collaboration that we have had with other across the world. It was not only for emergency surgeries or other surgeries, but all the domains were just included. So we shall have time for discussion for this, and there is also a guideline about this this ongoing timing of surgery after COVID-19. I call upon Dr. Ruhosha. Okay, he's now there. Dr. Matthias Ruhosha is a general surgeon working at the Kabwe District Hospital, and is also a principal investigator at the Kabwe Hospital in the Global Surge Hub, Rwanda. Now they were just conducting the Cheetah clinical trial. He's going to present on surgical site infection after gastrointestinal surgery in the high, middle, and low-income countries. This is a prospective international multi-center call to study. Actually, this was a Global Surge 2 cohort that we did, and it's the one which had shown that we have to do some clinical trials to decrease surgical site infection. And the first one was the falcon, the other one was the cheetah. So, Dr. Hosha, you are the most welcome. You are having 10 minutes. If you can go below, that's fantastic. Thank you. Thank you.
What did I do wrong for me to only get 5 minutes? Thank you very much, dear moderator. So as you can all see, the study is titled Surgical Site Infection After Gastrointestinal Surgery in High, Middle, and Low Income countries. And this was a prospective international multi-center cohort study. So as an introduction, surgical site infection is actually among the most common hospital-acquired infections, and it is a serious burden to the patient and the hospital itself. So data shown from the US suggests that SSI costs $10 billion in the United States. We do not have statistics here. So it results in catastrophic health expenditure and impoverishment to the patients. So comparable worldwide data on incidence and burden of surgical site infection is lacking. So most recommendations of surgical site infection prevention were actually developed from high-income countries, and this might lack validity in resource-constrained areas. So identifying gaps in the incidence of surgical site infection in global health settings actually was the aim of this study. So the methods, this was, as I said before, an international multi-center prospective cohort study, and investigators were recruited via global search network, social media, and also personal contacts. Countries with participating centers were also grouped into high, middle, and low income countries according to the UN Human Development Index. So they then consecutively sampled patients undergoing elective and emergency GI resection during the chosen 2 weeks period between January 4th, 2016 and July 31st, 2016. And we excluded clean surgeries or other GI surgeries which had the lumen not entered into. Local investigators were able to upload records on REDCap system, and data validation was done. So the primary outcome here was the measure of 30-day surgical site infection incidence. And here it is important to note that a mandatory online surgical site infection training module was completed by all participants in this study. And the secondary outcome measures were the clinical effects of surgical site infection. And these included 30-day postoperative mortality, prevalence in perioperative antibiotic administration, and 30-day postoperative reintervention incidence, and the prevalence of antimicrobial resistance on surgical site infection, and in-hospital incidence of SSI, but also overall 30-day SSI incidence. As a result, in total, 13,205 patient records were entered into REDCap. 700 plus were excluded, and 12,539 participants were actually included. And these were classified into high income, middle income, and low income countries. So 12.3% of patients had SSI infection, and 6.7% of them were diagnosed before discharge, And the unadjusted SSI incidence varied between countries. We could easily see that in high-income countries, only 9.4% of patients got SSI, compared to the 23.2% in low countries. And the death rate was 1.9%. But also the mortality varied, and it was almost the triple in low-income countries compared to the ones in high-income countries. The hospital stay was also longer in low-income countries compared to to high-income countries. And patients in low and middle-income countries were the most likely to receive post-operative antibiotics, and the course of those antibiotics were also longer in low and middle-income countries. As discussion, the burden and clinical effect of SSI on patients undergoing gastrointestinal surgery is identified in many parts of the world. SSI affected 12.3% of the total patients recruited and who met the inclusion criteria here. And the incidence remained higher in low Human Development Index countries compared to the ones in high income countries. So delayed return to work or to school due to a prolonged hospital stay carries a societal burden, which is likely to be greater in low and middle income countries. And post-operative course of antibiotics were longer, as I said before. And though there was randomized evidence that short post-operative antibiotic courses are safer as long antibiotic courses, this evidence was not actually derived in this study, and we should put caution not to immediately change the practice. So we found an association between SSI and death with a threefold increase. Patients who had SSI were 3 times more likely to die compared to the ones who did not. And this study, in this study, the failure to use available surgical safety checklist was associated with a high surgical site infection rate. So countries with a low Human Development Index carry a disproportionately greater burden of SSI than countries with middle and high income countries. Thank you very much.
Thank you very much, Dr. Matthias Roja. You can take a seat, and we will be having a discussion soon. So you see, we were just having a reason of doing some clinical trials on the surgical site infections. Probably also we shall just hear from the cost of this. So I'm calling upon Dr. Hirwa, GMV, who is the ENT, senior ENT resident. Is going to present a paper called Clinical Presentation and Factors Leading to Complications of Deep Neck. This paper, it was a research done by Munezero Eric, who died when he was still in, who died during his training, and because it was among us, I would like just to request you to have like 1 minute to remember him because of he has contributed to the knowledge. You can just stand up, please, for 1 minute for him. Okay, thank you very much. Now is the floor for Dr. Jem Vihirwa to take through this presentation. Thank you.
Thank you very much. I'm Dr. Hirwa. I'm a senior resident. I'm a senior ENT resident. I'm going to present. It is a case who has presented, who has been published in Rwanda Journal of Medicine and Health Science. So it is about clinical presentation and the factors leading to complication of deep neck space infection at the University Teaching Hospital of Kigali, Sehashika. It was done by Dr. Munezero, Dr. Nchogoza, Dr. Mvuche Jean Paul, and Dr. Dave Shai. It is an American HRH. So about the background, deep neck space infection, it is an infection in the potential spaces and also facial pain along the neck. So it is characterized by rapid progression and life-threatening complication, including death. So the facial pain of the neck was subdivided into two categories. There are superficial and there is deep fascia, and also is the relation to the hyoid bone. So we have spaces above the level of the hyoid bone and have spaces below the level of the hyoid bone, and also have spaces which account the entire circumference of the neck. So globally, the incidence of deep neck space infection was decreasing significantly. So this decreasing was in favor of widespread use of antibiotics, also development of new diagnostic tools, including CT scan and MRIs, and also there is an improvement in the general population about the oral hygiene. We are going to say that the most odontogenic neck, the most cause of neck infection was odontogenic cause. So, but despite this improvement in diagnostic tool and also use of antibiotics, in low and middle income countries, there are still a significant number of patients with deep neck infection, which increase morbidity and mortality. So the method for this study was cross-sectional. So it is conducted at University Teaching Hospital of Kigali in a period of 15 months. So the study was conducted after getting approval from the responsible institution. So we classify according to the patient consultation, the patient who consulted early, intermediate, and late. So the data was processed and the result was grouped. For the first result, they are considering the social demographic characteristics of the study patient. So the male and the female was in a ratio of 1 and 1.3. So the more predominant group was 0 to 10 years with a percentage of 33, and the second group was age above 50 years with a percentage of 18 years. And the majority of our patient was from the rural areas. This is the table giving the information. So for the clinical presentation, timing of consultation, and also complication and also stage. So the majority of patients consulted with neck pain, swelling, and fever. And also the minimum duration of symptom was 2 days, and the maximum duration was 45 days. So the majority of patients was consulted in a late phase. So the symptoms above 7 days in 40%, and also only 25.8% was consulted before 3 days of symptoms. So the clinical presentation timing for this patient, also the findings on a physical examination, 97 of patients consulted with neck tenderness, and also 92 with fluctuation. The most involved space was submandibular space at a percentage of 50%, followed by peritonsillar space at a percentage of 13.6, and also 13.6 of patients consulted with rhodoid angina. So the most prevalent cause was odontogenic, means dental extraction, tooth extraction, followed by tonsillitis and pharyngitis. And also the diagnostic tool was final aspiration in 70%, 15% use ultrasound, and 11% using a CT scan. So in 90.9% of patients, the treatment was incision and drainage, and also associated with antibiotics. So out of the 66 patients enrolled into the study, 14 patients has a complication, and the most prevalent complication was necrotizing fasciitis in 66%, airway compromise in 28%, and also the main hospital stay was 10 days. So the prolonged hospital stay, which means more than 1 week, was observed in 45 of patients. This is a table to give the summary. So the factors for complication, the patient who consulted in a delay phase, is more than 7 days, and the patient above 40 years. The factors for delayed hospital stay was duration of consultation, which is more than 7 days, and also the patient who presented with the complication has a long hospital stay. So as a discussion, so the above findings comparing with the other studies done was significantly for our patient, and also when you consider the sex, it looks like there is no sex difference between male and female according to the deep neck space infection. Conclusion, the most common clinical presentation and risk factor for deep neck infection are neck swelling and neck pain on background of dental infection, and also the delayed presentation and advanced age was among the risk factor for prolonged hospital stay and also associated with the complication. So for recommendation, so we encouraged for oral hygiene and also a consultation in case of patient develop swelling or neck pain. So thank you for your presentation. Your audience, this is the difference. Thank you very much.
Thank you very much, Dr. Irwa. It was very, very interesting. You have just also to know what is being done in ENT, rather than calling all the time Dr. Isai like I'm doing. So I'm calling upon all the presenters of the second session, Donna, Rachel, Alphonsine, where is she? I'm not seeing her. And we are going to have a little bit on the discussion, and we are going to receive some questions for them, but you have to target very well the questions. Others we will send them over the YouTube. Okay, sorry, we can just start.
Thank you. Maybe for the sake of time, I think we have to cut short the discussions because we are already very behind on the schedules. But I had one question that I want to address to Donna and Rachel. So we are moving up in the methodology designs. So we started by a 2x2 pragmatic randomized controlled trial, which is a double-blinded. So we did a SWAT, a study within a trial. We did a cluster randomized control trial. Now the question, maybe it's just asking advice. How do you recommend that we go about so that we build capacity in our methodological people? So we do think, methodologically speaking, we have a big gap that we should be filling. So how would you advise us to go about that?
We can take another question before we respond. Okay, none? If there is none, I have, yes, Prof. So.
Thank you very much. There was a discussion on Farcon adherence. No. It's about recommendation on what we are using in antibiotics, or the recommendation when we are talking about avoidance of SSI, and we found that the current practice is not cost effective and is not causing any change. I wonder whether you looked at the substitutes. Should we just use the common soap like some of us use, or what do we have? What do you recommend? That was my question. Then the person who presented on wanting to involve community as part of our research. I think even Prof. Austin talked about it. So the question is, in Rwanda, we know that we have, at the base, we have community health workers. Has anybody tried to see their role in when you're doing research or implementing findings on research? Thank you very much. I don't remember the people I'm asking questions to, so you have to figure out when we ask questions. Thank you.
Okay, thank you very much. And I have got one question from online. He's saying, I would like to echo on the point mentioned by Prof. Austin about the country-related data and its access. My concern about country-related sample size, that may not be sufficient enough for a statistical analysis. We should give insight about local situation. Question one, it is possible to take into consideration the size of the sample at a country level during the study design? And how do you facilitate and empower local team at country level access the data and conduct post-analysis after publishing the main study in order to get local situation awareness? This question is go to Rachel and Donna. Probably this one who sent it was a statistician. I don't know. Okay, good. Okay, you can respond. Thank you.
Say that I can't answer that definitively. I mean, obviously it would be possible to have individual sample sizes for each country, but how that interacts with itself in the overall sample size, I wouldn't be able to comment as a non-statistician. Have you got nothing to add? I'm sorry, but we can take that question back to our statisticians and we can get back to you on it. So if I also just caught this correctly, so Forster, I'm very sorry, I didn't hear most of your question, but it was relating to building capacity, I think. So do you mean in terms of building capacity beyond the trials that we've already got running in order to run more research within Rwanda?
Thank you, Rachel. Actually, I was meaning building capacity and empower people, local people, to be able to design complex trials.
Mm-hmm. Okay, so, I mean, I think what you're already doing is beginning to do that. So, I mean, obviously we've got all of these wonderful people in this room who've all participated in good quality research. What we're also developing at the same time for the next, what we're calling Global Surge 2, for this iteration of funding that we have until 2026, is an education program which will be designed for and with all different levels of staff, so it will be applicable in all of your different settings, dependent on all of your different roles. So that will equip you with some of the knowledge to kind of begin to design research. Does that answer your question, Boston?
Yes, thank you for answering such way, because actually I was knowing the answer. So I wanted that we highlight that the unit is engaging now more in capacity building, and you have a huge education and training committee doing that. And one of the areas that we are going to emphasize on is that, so that we empower people to move a little bit higher in their skills, both in research as researchers, but also in the methodologies and statistics.
Excellent, thank you. And just to address the other room, so in terms of what we'd recommend for surgical site infection, was that your question? Mm-hmm. Iodine. Mm-hmm. Yeah.
If there is no difference, and we know they're expensive,
mm-hmm.
So have we already thought of substitutes for that?
So if I understand,
what do we recommend?
If I ask understand your question correctly, that because there's no clear benefit of the alcohol-based skin preparation solution, then we would recommend using iodine, because it's cheaper, it's more ubiquitous, it's available everywhere, and quite often these costs are carried by the patients in some countries, perhaps not in Rwanda. So we would recommend just using the cheaper option because there's no clear benefit of alcoholic chlorhexidine. With that said, we're continuing to run these platform trials. Cheetah was the second trial. We have another trial looking at a surgical site infection, which is more of a perioperative trial, and it's called Penguin, which is running all around the world at the moment. We also have a platform trial that's in development that will be looking at different types of skin irrigation prior to surgery and washing, as well as impregnated dressings. And we have lots and lots of trials that are all looking at individual different interventions that might or might not improve surgical site infection, and that's the reason that we're continuing to do these trials essentially.
Okay.
Thank you.
Thank you.
Are answered. A round of applause to all of you for this second session, which was interactive. As they are gaining their seats, I would like to ask to go for the next session, which will be about the community engagement. As Prof. Musi just asked, what is the role of community health workers or any person at the lowest level? What can be their involvement with research? So I'm going to welcome Mr. Michael Bahrami Hisari. I hope I've pronounced it well. And he's a patient and public involvement officer at the University Hospital of Southampton in England, and community involvement coordinator for the COVID-related effect on ethnic minorities in England and Wales. And he's trained as a microbiologist. He has worked on the link of bacteria to cancer. And besides that, he's also passionate about science education and worked in developing local science kits for undeserved rural public hospitals and schools. So thank you very much. We're welcoming you, Mr. Michael Bahrami Hisari.
Muraho, Ndi Michael, Rwanda. Apologies, that's the only Kenya Rwanda I know. It's my first time in Rwanda, and lovely, lovely country. We'll be here for a week, and I really look forward to working with the Hub team and the different researchers. So I'm here to talk about community engagement and involvement in global health research, but I did not make this presentation alone. I actually had help from Emmanuel Munyaneza. He's here. And Emmy, I don't know if Emmy is here. Please stand to be recognized. So Emmy is one of our community representatives, and Emmanuel, the CEI coordinator of the Rwanda Hub. They've been very helpful in pointing out the different issues of the Rwanda Hub and ways that we can engage with the community. So I will do my best to explain to everyone the importance of CEI, or community engagement and involvement, in 15 minutes, hopefully, so that the talk isn't too technical, but hopefully you are able to take a step back and reflect on how to make this wonderful research that the Hub is producing relevant to patients who might not have as much education, levels of education as all of you. So, outline of this talk, we'll talk about what CEI is. We'll talk about what is the difference between participation, involvement, engagement. We'll talk about its importance. And then I will give some examples that we've done in GSU, but also some future examples of what we plan to implement in GSU, and in particular, Rwanda. The kind professor had a question about community healthcare workers, and we actually have written a project called Pigeon, which aims to empower community healthcare workers in terms of educating their communities in terms of research and surgery. So, first question, and I will be showing you a series of pictures. It's very important that we define what a community is. So, I'll show everyone a picture, and amongst yourselves, you can try to ask, which picture do you think best describes a community? So these are 8 pictures, A, B, C, D, E, F, G, and H, so just for context, all of these pictures represent the different hubs that are part of GSU. So picture A are commuters in a city in India called Chennai. Picture B are healthcare workers in Mexico City. Picture C are hip-hop teenage dancers in Lagos, Nigeria. D are farmers in Rwanda. E are Benin football fans. F are kente cloth weavers in in Ghana. G are HIV activists in South Africa. And letter H, these are men with colostomy bags, stoma bags, and they have a support group because there's a stigma sometimes if you have a stoma bag. So they play football together, and it's a support group to help them go through life with a stoma bag. So ask among yourselves, what reminds you of a community, and which of this is a community? Any ideas? So I see some say all of them, yes? The short answer is this. They're all communities. Why? Because how do we define a community? It's a group of people connected by all of these things. Do they live close together? Ethnicity, religion and culture, occupation. There are some health conditions that are occupation specific. Health condition, special interest, very important, lived experience. In research, global surgery or any form of research, community is very context specific. For example, one of our studies is that's in the pipeline is called CRANE, and it aims to develop a nutritional supplement for people about to undergo cancer surgery. So in this sense, the community that you should be involving with at the start would be people with experience of cancer surgery, but not just only them, but they have families who take care of them if they've undergone surgery or chemotherapy. It's also important to engage with their carers and their families. So community is context specific. Now, how do we define CEI? The official definition of the NIHR, since the NIHR funds GSU, is CEI is a process where you work collaboratively as partners with communities who are most likely to be affected by research. So if, for example, you are doing research on SSIs, who are communities that might be most affected by SSIs? Maybe these are people who might live far from the hospital, who, if they have complications, might find it difficult to go to the hospital. That's CEI. That's the definition of CEI. And here are some synonyms if you read the literature. Different literature will use different words to describe CEI. Some call it patient and public involvement, PPI, patient engagement. They all mean the same thing. So what is an example of what we did prior to this day in terms of GSU? So we did a CEI project in Ghana called Tiger. So one of the biggest problems in some areas of northern Ghana, in particular the Tamale region, would be a lot of people suffering from inguinal hernias. The problem is there's not enough surgeons who can actually perform inguinal hernias. So the idea is it possible to train non-surgeon physicians to actually perform inguinal hernia repairs? So what did we do? We wanted to find out if patients found this acceptable. Did they think that were they comfortable having an operation by a non-surgeon physician to repair their inguinal hernia? So what did we do? There were 31, so we consulted with 31 patients, 2 community chiefs, community finance officer, a local politician, very important, to talk about the acceptability of this proposed project. So what's really interesting is that this part of the project was actually done even before the actual protocol was written, because you want to find out, you want to look at the mood of the community. Are they accepting of what you want to propose or not? So it's very important to involve communities at the start. So what were some of our outcomes and results? First, community said, most of the people that you were talking to are men. You need to also talk to women, because women also suffer from inguinal hernia. Most of the people were happy that a trained non-surgeon physician repairs their inguinal hernia, but they emphasized that there needs to be proper translations. So lots of countries have local languages, and so it's very imperfect language that patients can understand. We were also able to publish this as a case study in a community engagement journal in the UK. So now, the Tiger team is actually writing the protocols. I think they're developing training modules. They're just having to go through quite complex ethical hoops. But hopefully, fingers crossed, this happens. So, a brief explanation. So oftentimes, people talking about community engagement and involvement, they tend to use the terms participation, involvement, and engagement in the same, thinking it's the same thing. It's actually quite different. So when we say the term participation, this is when the patient is the subject of your research. So if they join a trial, or if they join research, if they join qualitative research like a focus group, that's participation. So they are the subject, and what comes out of that is actual data. What about engagement? Engagement is when you share your findings, not with other surgeons like what's happening now, but by going to the community and sharing your results with them. And what's the beauty of Rwandan society is that you have the structures in place. For example, you have the concept of umuganda. Every fourth Saturday, you all go out on the streets to clean the roads. That's community working together to make the country clean and beautiful. You can actually use this an event to actually talk to regular people who might not be surgeons, who might not be physicians, who did not go to university, and talk to them about research and the importance of being healthy. That's engagement. And what about participation? This is where you gather important members of the community and ask them advice. In some countries in the world, if you are to run a trial, for example, HIV trials in some countries, you are required to have a community advisory board. These are members of the community who advise the researchers on the best way to implement their project. And you know, this can actually help with impact, because impact in research can be measured in many ways. It could be journals, it could be the number of people you recruit, but it could also mean how much the community values what you do. And by community, we mean people who might be far from Kigali, away from the city capital, in the countryside. That's impact in terms of CEI. And that's the focus of CEI, involvement and engagement. I'm going to cut short this talk because I want to go to the heart of the matter. I would like to show you what do we plan to do in terms of CEI in Rwanda. So apologies, I'm going to jump a few slides forward. Also to say that CEI is such an important aspect of research now that in 2020, the United Nations, through UNICEF, actually published the standards, the minimum standards for community engagement in research. So slowly, the world is recognizing how important you need to engage communities when you do research. So there are some examples not in GSU, but I just want to say that the one thing that we are doing in GSU, and this is in Cape Town, South Africa, is this SWOT. So it's a SWOT. It's a study within a trial called PANDA. And it's a qualitative research that aims to look at how patients get access to surgery and what are their challenges in getting surgery and getting through follow-ups. Now, that might sound quite ordinary, but what's really interesting is that the people who are conducting the interviews with the patients are other patients themselves. So what we did in Birmingham is we asked our team in South Africa, could you identify 2 or 3 patients who are interested in research? And we trained these 2 or 3 patients in qualitative interview skills. And so what they do is they interview other patients, they send us the recordings, and we make transcriptions of those. So in that sense, you actually have community members who are now researchers. So what are some current and future CEI projects in GSU? What have we done so far? So with the different hub CEI leads, we developed a CEI training course. All the hub CEI leads, Emmanuel included, have undergone this course, and tomorrow we will be having this for the Rwanda hub. So it's about 3 or 4 hours. It's a workshop, so it's not just one person talking. It will be a lot of people talking and sharing ideas. So some hubs have started to recruit members from the community in their hub CEI advisory boards. This study, Pigeon in Rwanda. So this study, which I think the protocol has been approved, aims to look at how community healthcare workers can help in post-operative care in the community. So for example, once a patient is discharged, they would still need to care for their surgical wound. What can community healthcare workers do in helping with this? So it involves interviewing community healthcare workers, training community healthcare workers to interview other community healthcare workers. In India, one of their challenges is that in rural areas, patients are unable to go to a tertiary hospital. So how then could their community healthcare workers do the same thing? PANDA, as previously mentioned, and this project, which was conceptualized about a month ago, it's called SPECIES. And SPECIES means Survey on Patient Experience on Surgical Site Infections. It's called SPECIES because if you notice, all the trials from GSU are animal names. And this study, this survey, will encompass all the animals, all the trials. So essentially, it's a survey for patients that look at their experience on SSIs. One of the outcomes we are trying to avoid are SSIs. And we are always looking at it from the perspective of the hospital. Will it increase a patient's stay? Will it cost the hospital more? Will it increase mortality rates? But what we did is we looked at this phenomenon from another angle. We said, what if we ask the effect of SSIs on the patients themselves? And so the idea is, I'm going to skip to this slide. It's a short questionnaire that we ask patients about their experience with SSIs. We ask them, because you have an SSI, do you worry about your finances? How is your mental health? Do you worry about that? Are you able to go back to your normal activities? Are you able to go back to work? Are you able to care for your children or your families? Because these are factors that affect the patient outside the hospital. And that's just as important as factors inside the hospital, such as sutures and changing of gloves. And I hope you all can join us in this journey of CEI. If you have any questions, I'm happy to answer them after this conference, or please approach Emmanuel. With that, Murakoze, thank you very much.
Thank you once again, Mr. Michael Baharami Mehesari. This was some good, insightful talk. But I myself did not know we can have patients involved actively with that community engagement and involvement. So thank you very much. We're going to welcome our third session on general papers, and it's going to be led by Dr. Christophe Mhirimbanyi, who is a consultant general surgeon at Kibagabaga Hospital and a fellow of the College of Surgeon, COSEXA, and he is the associate researcher for NIHR Global Health Research Unit. And Dr. Mhirimbanyi has more than 20 papers published in various international journals, peer-reviewed. And he has contributed in significant impact on surgical care in our country and beyond. So welcoming him to welcome our presenters. And please, presenters, you have 5 minutes for presentation. The first minute it will be a timeout. I beg you.
Thank you, Glass, for the microphone. It's a great pleasure to moderate this third session of general papers. In this session, you have 4 presenters. And without delaying, let me call upon the first presenter, Mrs. Esperance Muhawenayo. She's presenting on global variation in postoperative mortality and complications after cancer surgery, a multi-center prospective cohort study in 82 countries. Thank you.
Good afternoon. As they said, I'm Esperance Muhawenayo. I'm going to present on global variation in post-operative mortality and complication after cancer surgery, which was a multi-center prospective cohort study done across 82 countries worldwide. Looking on background, 80% of individuals with cancer will require surgical procedure, while 25% of them will have access to effective surgical care. The previous studies was shown that there is a significant global disparity in surgical outcome. In lower income countries, 2 to 3 times will have major complications, even die after cancer surgery. The reason of this study, it was a little known about factors contributing to early death or complications after cancer surgery. It was a multi-center. Previous studies was standalone on single tumors or any type of cancers, but there was no data comparing outcome across income settings. The post-operative outcome in breast and the colorectal and the gastric cancer surgery in the hospital worldwide was focusing on the effect of disease stage, complications on post-operative mortality. This study was done during a period of 10 months from April 2018 to 2019 in January. And 428 hospitals worldwide was participated across 82 countries, and the distribution was 20 from Africa, 17 in Asia, 13 in Europe, and 5 in North America, while 2 was from Oceania and 6 in South America. I said that the primary outcome is to show the incidence of mortality and the major complication rate within 30 days after cancer surgery. It was a multi-center. The analysis was done using statistical regressions, and some models. Going on the results, the breast cancer was the first to be enrolled with the high number of patients. When we come on mortality rate, the gastric cancer and the colorectal cancer was come on first stage with a rate of 5.4 in the gastric cancer, while in the colorectal it was 3.3. Comparing the country incomes group and the stage of the disease, the proportion of patients with later stage disease who had surgery was greater in the upper middle income countries and lower income countries for all three cancers groups. 30 days mortality was seen to be higher in gastric cancer in lower income country, and for colorectal cancer it was greater in the upper middle income countries, while for concerning the breast cancer there was no difference in mortality rate. The proportion of patients with major complications was almost similar across all countries group, while any complication occurred more in the colorectal and the gastric cancer. Post-operative death after complications was partially explained by patient factor at a rate of 60%, and the hospital or country by 40%. The absence of consistent available post-operative care facility was also associated with 7 to 10 more deaths per million major complications in lower income countries. Cancer stage alone explained the little of the early variation in mortality rate post-operatively. Mortality reported in this study across low-income countries for both gastric and colorectal was 10.1 and 7% respectively, and this was shown as higher than current global estimation. Existing perioperative mortality rate in literature are limited by the absence of standardized reporting and risk stratification, and often derived from single center studies. Across gastric and colorectal cancer, variation in 30 days mortality between high-income countries and low-income countries was shown after both emergency and elective surgeries by a rate of 7.1 versus 18% to 1.9 versus 9% respectively. For conclusion, a high level of mortality after cancer surgery in low-income countries was not fully explained by later presence of disease, but also was explained by patient factors at that rate of 60% and the hospital incomes structures at 40%. Excess mortality after major complication was mediated by the absence of post-operative care infrastructure in lower middle income countries at a rate of 20%, and the upper middle on 22%. Considering that the effective surgical care plays a crucial role in the preventive of death from cancer and require a system with high quality through the post-operative period. Thank you.
Thank you, Mrs. Esperance. Let me call upon Dr. Isaïe Nchogoza to present on the effect of hospital facilities on patient outcomes after cancer surgery, an international prospective observational study. And Dr. Isaiah is the senior lecturer, and he was introduced before, and the ENT surgeon and the deputy of NIH Rwanda. Thank you.
So I'm going to present on effect of hospital facilities on patient outcomes after cancer surgery. It's a study by Global Search Collaborative. The hospital facility vary worldwide, and little is known in a country of low income, and some studies done, the two studies done, one in 2009 and one in 2011, talked about the comparison between difference in mortality vis-a-vis facilities, and also the association between system characteristics and the mortality. And as this has been done in countries with high income, we wonder if system characteristics may impact early outcome following surgery for cancer worldwide. So now this study has done parallel to Global Surge study, and it was a multi-center international prospective cohort study enrolling consecutive patients who undergone surgery for breast, colorectal, and gastric cancer. And the outcome, the primary outcome was 30 days mortality and major complication rates. And there was a hospital level survey developed and designed with help from low middle income countries. And the survey was open for 8 weeks period. So it enrolled in total 9,685 patients across 238 hospitals in 66 countries of all different incomes. So all country incomes were involved, from high income to low income countries, and all 3 cancers were represented. So the high income countries were the more prevalent with facilities, and those facilities we are talking about are the ones necessary to manage cancer surgeries, including the ones from diagnosis, imaging, post-operative care, and oncological management. The country, the developed high human index rank from 150 and above were prevalent with more facilities. And when you see the hospital with the patient treated in the hospital with the greater number of facilities, we are less likely to die within 30 days following cancer surgery. And when we see in total, the sampling in high income countries were 57%, and 30 days outcome was worse in hospital with less resources, and in less resources, the mortality was 4 times higher than in high resources, and 3 times lower capacity of rescue compared to high resources. And improving hospital resources could save, in the low income countries, could save 3 additional lives per 100 surgical cancer operations. In summary, like conclusions and recommendations, the availability of hospital resources has been thought to affect the clinical outcome in low-income countries. But with this study, this was clear that the availability of hospital resources could help to affect the clinical outcome in low-income countries. And the hospitals with high level of infrastructure and resources have better outcomes after cancer surgery independent of country income. So as recommendation, without urgent strengthening of hospital infrastructures and resources, the reduction in cancer associated mortality associated with improved access will not be realized. So we have to increase infrastructure and resources in low-income countries to improve the outcome of post-operative cancer surgery. Thank you.
Thank you very much for a good presentation. The next talk is by Dr. Teobar. He's a senior resident in general surgery, and he's going to present on the analysis of anatomical content in the surgical notes using case anatomical knowledge. The floor is yours.
Good afternoon again. So thank you. I am going to present this work, the analysis of anatomical content in surgical notes using case anatomical knowledge index. It is a mixed method study. First of all, I want to extend my gratitude to my supervisors, Prof. Nirenganya and Prof. Gashego. So anatomy is a crucial entity when it comes to safe practice of medicine and surgery. But we observe a huge variability in anatomical details when you go through surgical notes, and that is observed among most common procedures performed at CHUK. So the lack of standard surgical notes and guide of important anatomical details to be recorded has a consequence of leading to shallow and superficial anatomical description in surgical procedures, which have an impact on documentation and teaching purposes. So the objectives of this study were to improve the documentation of clinically relevant anatomy in surgical notes for patients and teaching purposes. Specific were to assess the score of anatomic content in the surgical notes using CAC score, to identify factors influencing the quality of anatomy, as well as exploring perceptions of surgeons and surgical trainees when it comes to anatomy documentation. So it was a mixed method study with a sequential explanatory design conducted at CHUK, involving a quantitative phase where 119 medical files for patients operated for hernia, cholecystectomy, and thyroid were assessed using the CAC score. The demographic and variables of interest collected using CAC score, and the factors were evaluated using Likert scale survey, perceptions through an open-ended questionnaire. This study was approved by ERB, CMHS, and CHUK Ethics Review. So for the main results, we found out that the overall CAC score is average. So this was 11/15. So the factors which were significant were the type of disease and surgical procedure. From participants, they said to us that the use of cadaveric dissection as anatomical teaching tool as well as level of training of surgical note taker can influence also the quality of notes. So we conducted a qualitative part on participants, surgeons and residents, and among the perceived challenges leading to that average Kaki score were lack of anatomy course integration in surgical practice, also the heavy workload as well as a low consideration to given to anatomical details when recording procedures. So the perceived solutions were integration of cadaveric dissection sessions to implement a medical file with a space dedicated to anatomy details, as well as organizing regular anatomy content audit and feedback, as well as increasing awareness about the importance of good documentation of anatomy details. So these results were in accordance with other studies we have seen, which stipulates that nowadays there is an insufficiency observed into anatomical terms, especially in books used during clinical teachings. And also, the type of disease and surgical procedure has been also identified by other studies, and this is mostly related to challenging anatomy, especially in thyroid and hernia. So the majority of the participants expressing lack of anatomy integration in surgery as well as the heavy workload, there is also confirmation from other studies. So as a conclusion, the content of anatomy in surgical notes is average. It is influenced by type of disease as well as surgical procedure and the level of expertise of note taker. The cadaveric dissection can help to increase that level. So we recommend to empower surgeons and trainees through regular regional cadaveric dissection sessions, regular anatomy content audit, as well as organize regular awareness workshops about importance of documenting anatomy details in the surgical notes. Thank you very much.
Thank you, Dr. Teoban. Let me call upon the last presenter for this third session, who is Eric Shingilo, a finalist resident in neurosurgery, who is going to present on assessment of relationship between clinical manifestation of Chiari formation type 1 and the cerebral tonsil herniation measurement within the foramen magnum. Welcome, Dr. Eric.
Thank you for this platform to present to you. I'm Eric. I'm resident in neurosurgery. I'm finishing my training. This is a part of my dissertation, and I do recognize all neurosurgical team, mentors, and who helped to go through this important study. So without delaying, I would like to explain a bit on what is Chiari malformation type 1. When you see this image, this is what you are going to see intraoperatively when you see the patient with Chiari 1 malformation. Then on your left side, this is what you are going to see when you are requesting the MRI of the patient with Chiari 1 malformation. We'll be able, in normal population, this is what we call tonsils. This is the patient who is in a prone position, at the level of your neck, and you see the subclavicular bone. Here we have a C1 lamina. So all these two structures, this is the right tonsil, left tonsil, were not supposed to be below this line we are drawing, foramen magnum. And radiologically, when the radiologists will do the MRI, when they draw this line between the option and basion, when it goes below this drawn line, it's where they call it a Chiari malformation, type 1, which is congenital. The Chiari 1 malformation is in the literature, it's full of controversy from management and the diagnosis. So many studies have even not shown that any extent of a cerebral tonsil herniation does not correlate with the severity of symptoms. So, and based on MRI, many patients could get different views from either radiologists, neurosurgeons, or internists because they have done MRI and only when they saw the 5 millimeter cuts below the foramen magnum, the diagnosis of Chiari 1 will be made. But the question is the Chiari 1 malformation a sagittal disease? Would you only rely on descent of a cerebellar tonsil herniation of 5 only as a diagnosis? Or if we see the cerebral tonsil in a 3-dimension, could reflect better the severity of the disease? Another concept we are bringing in the literature can also be the volume of cerebral tonsils reflect better the severity of Chiari 1 malformation. Those are the questions we're asking ourselves, and we go on. We did an analytical cross-sectional study. We measured craniocervical MRI, and we also see the clinical information, and we did headache severity. We used the numerical pain score and the severity of neuropathy using a modified Japanese Orthopedic Association score. And the length was measured in sagittal and coronal view, and the width was also calculated on axial view. Now, if you see this image, is trying to characterize what is called foramen magnum and the tonsils, 2 tonsils filling within the sphere like foramen magnum. Because most of the symptoms result from the overclouding of tonsils within this there's a container and there's a content. Take tonsils as a content and the foramen magnum, which is a sphere, as a container. So we thought the tonsil is a form of cylindrical, and the foramen sphere volume was calculated using ellipsoid formula. Foramen magnum volume was calculated using a sphere formula. After going through the ethics and the ELB approval, we got an approval from University of Rwanda, and they started the research. So based on calculation and power calculation, we got 96 patients. 96 patients. The most common we found were female, which occupy 61%, and the male, well, 38%. The distribution of symptoms, we found the limb paresthesia are most common, and interestingly, the myelopathy was also most common, and the C-links was in 5% of patients, and scoliosis associated with the CM1 was in 80%. Interestingly, the severity of headache using numerical pain score, the most patients presented with 59% were severe, a moderate pain were in 41%, and the mild in 5%. The severity of myelopathy, according to modified Japanese Orthopedic Association, most patients, 81%, were in the category of mild, and moderate 11%, and severe in 7.3%. The measurements within the foramen magnum and tonsils, the interquartile range between left and right, and left was 11 millimeter, and right was 11.2 millimeter. And the overall foramen magnum transverse, transverse diameter was 38. So the epicenter of all of our findings are based on these slides, which is showing, remember what we want to prove is to prove if the volume of cerebral tonsils can be useful in making diagnosis better than doing imaging in a sagittal condition. So see how when we see how the more the patient, the more we got more volume of cerebral tonsils, the more we become myelopathic, as shown with this image. So the most interestingly, when we take the ratio of cerebral tonsils over the volume of foramen magnum, which we call TF volume ratio, there is a crescendo ratio which is showing the ratio which is really proportional. So this really a new finding when we are approaching the sharing malformation. So without taking many of and again, point and three, when we computerize or we measure the tonsil in left and right, there is in the coronal and in sagittal, there was a big difference with a p-value of less 0.01. So that's why in the one recommendation, it's always important to computerize both sagittal and the coronal measurement. So to conclude, to discuss, there is many literature which has shown that two morphometric are not reflective of severity of sharing malformation type 1, and have recommended other additional imaging and or modalities to diagnose better disability. So, and then we still the literature not answering if the cerebral 1 malformation is sagittal disease, considering 5 millimeter cutoff for cerebral tonsil in a mid-sagittal line. So we conclude many studies, as I said, have not shown the relationship between severity and the cerebral tonsil herniation. We think the volume of cerebral tonsil and the TF volume ratio has shown the relationship between severity of headache and even with myelopathy. So our study shed a light on cerebral tonsil volume and TF volume ratio as a predictor of severity in a patient with CHAR1 malformation. So we really recommend if a TF or tonsil foramen magnum volume ratio can be used as diagnostic tool in CHAR1 malformation, this will need another validation studies on this. I thank you.
Thank you very much, Dr. Shingiro, for the good presentation on CHAR malformation. The way we fight in theater and the way he's delaying doesn't match. But we'll go to the next about another session on general paper. This will be our second and the last session. So calling upon all presenters to kindly move forward. We're going to have the question and answer session will be at the last. So we're going to have 20 minutes. The 4 presenters, please come forward. 5.000 minutes. And we're going to welcome Mr. Emmanuel Munyaneza, who is a registered specialized perioperative nurse with a 15 years experience in clinical settings in Rwanda. He's based at Sashuka, and he's a lecturer at the College of Medicine and Health Sciences, and he's the community engagement and Involvement Coordinator of Global Surgery Research Hub in Rwanda. So he's the Michael of Rwanda. Thank you very much. Welcome.
Thank you, Dr. Grass. Thank you for giving me the opportunity of being a moderator for this last session, which is the very nice session considering to the previous ones. So let's go straight forward to the presenters. And let me start to Dr. Jean-Paul Rugambwa, who is a senior resident and who is going to present to us the study conducted with the title Element Influencing Catastrophic Health Expenditure and Impoverishment Among Patients Undergoing Abdominal Surgeries at the University Teaching Hospital of Kigali. Welcome, Dr. Jean-Paul. You have 5 minutes for your presentation, and then after all presenters, it's when we will have like a session of question and answers. Thank you.
Good afternoon. So thank you for introducing me for this session. So our colleagues and some of our lecturers, they have been presenting on clinics, but now I'm going to talk about also costing on top of the clinics so that we combine both the clinics and the costing. So I would first to say thank you to my lecturers who helped me to make this dissertation. So this goes to Dr. Allen and Prof. Faustin. So we are going to talk about the elements which are influencing catastrophic health expenditure and impoverishment among patients undergoing abdominal surgeries at the University Teaching Hospital of Kigali. So as we know, 150 million individuals worldwide, they may face catastrophic health expenditure every year from medical costs alone. So non-medical costs of accessing care, they will increase that number. So every year, 81 million individuals globally, they will face catastrophic health expenditure from surgical conditions. So, and 33 million face catastrophic health expenditure from the cost of surgery alone, and 9 million will face catastrophic health expenditure from associated non-medical costs. And through this presentation, I will show you how will be, what about our settings. So 3.1 billion individuals are currently at risk of catastrophic expenditure when they have to pay out-of-pocket money. So, and as we know, good health systems will deliver health services, preventive and curative, that make a difference in people's health, and access to these services can lead individuals to pay catastrophic health expenditure of their available income and push them and the households into the poverty. So poor health is a common consequence of poverty and vice versa, and the poor health will lead to poverty through the inability to work and generate income. So the methods we used to go through this topic, we used a prospective macro-costing study, and it took place at Ashika, mainly in the general surgery department. So abdominal surgeries patients from January up to June this year, they were recruited, adult people 18 years and above. And we used just the formula for the one sample situations, and roughly we got 265 patients, and we used the pre-elaborated questionnaire. So the outcomes, the primary outcome was the catastrophic health expenditure. The second outcome were direct and indirect costs. Of course, to see, we went through also to see the length of hospital stay. And data analysis and statistics, we used descriptive analytics. Non-parametric statistics test has been used. Correlation analysis and logistic regression. Overall, we used the software called Python 3, version 3. So the results, as you have to as a key of this talk. So we found that on the demographic side, the male, we found that the male were composing 50.2%. So the mean age was 44 years old of age. At 7% they were using health, those called community health-based insurances, and the rest they were using other insurances available in the country. So the education level of those patients who underwent abdominal surgeries was not quite high, as 59% they studied up to the primary level, and other people they have not studied at all, and only 41% they went above the primary level. So the average size of that population was 4 people per household. So we found that the abdominal surgeries which are performed at Africa, the main percentage for the emergencies, which had 59%, and the operation for those surgeries were 12.5%. So we found that the catastrophic expenditure was really high when we used the threshold of 10%. We found that 58% of the people operated on, they suffered the catastrophic expenditure when we take the threshold of 10%. If we use, by the time we used the 40%, which is commonly used by WHO, we found that 20% they suffered from catastrophic expenditure. So now, as this is a macro costing study, allow me to tell you that the costing annual household income is around $352. When we want to know roughly in Rwandan francs would be, every household would be getting 3,052,000 Rwandan francs. And when you want to see at the individual level, so every person found that would be getting $232. So now we found that the in-hospital cost for surgery at Africa would be $68 US, while the people they have used the insurances. Now imagine if they have not used the insurance, they would be paying around $688 US, which would be really a big amount. So the direct cost, the money they have to pay for the services, which the money goes to the hospital and the service from the hospital, was $43 US, and indirect cost to overcome the associated concerns about surgery was roughly $19. So now we found that the impoverishment for the patients who came to undergo surgeries, 84 came in just below the poverty line when we used the international line, where we used $1.9 US at that time. And once after undergoing surgery, so there was another $0.2. So generally, the length of stay for our patients who undergo abdominal surgeries were 5 days when we combine open and laparoscopic surgeries. And if we consider alone the open surgeries, the length of stay would be 17 days. When we look for the minimal invasive surgery, the length of stay would be 2.7 days. Then you have really to promote it. So now, we found that the risk factors for catastrophic expenditure, which are having really the p-value really very significant, were the length of stay, the size of household, age of head of the household, patient education, low level of education. These were really the risk factors we got from the multivariate analysis, which was among the many risk factors we got from the bivariates. So these findings would be the one to be discussed on. So going quickly to discuss our findings, as the time is allowing, now we found that as we found in the other literatures, our study found that the demographics, such as age, education, household, and work status are the risk factors for catastrophic expenditure, and longer hospital stay is associated with increased need the catastrophic expenditure, which is in line with other findings from other studies. So a high prevalence of catastrophic expenditure in our studies also observed in the general population worldwide. And once the surgery is really needed, about 43% of the world's population, they will face the catastrophic expenditure, and between 30 to 57% risk the likelihood of impoverishment expenditure. So now, to conclude, so this study showed that there is evidence of catastrophic expenditure among abdominal surgery patients, as 58% of abdominal surgeries performed in our settings developed the catastrophic expenditure, and obtaining abdominal surgery care has considerable economic impacts on the household level and individual level. Then, the patients who undergo abdominal procedures need to be backed by financial risk protection. Recommendations, as it is one of the key of these sessions, is that we have to avail consumables and drugs which has to be available in the hospitals, so that we reduce the cost for the cost of direct charges, because some of our patients, they spend too much of money going to look for the consumables, drugs which are not available. Then that increases the risk of catastrophic expenditure. Then we have to work on that side of direct costs. So we have to advocate to insurance side, so that the vulnerable patients who undergo abdominal surgeries, their cost has to be covered. So we have to promote and broaden the use of minimally invasive surgeries for patients who require abdominal surgeries. With that minimal invasive surgeries, there will be decrease of length of stay, which found that is the most risk factors which is leading to the catastrophic expenditure. And reducing the length of hospital stay would reduce the cost of surgery considerably at the provider, patients, and societal perspectives levels. Now, with this, we have to conduct additional studies which are determining the role of various abdominal surgeries, conditions in catastrophic expenditure for better future planning for our patients. So thank you very much. These are our references.
Okay, thank you, Dr. Jean-Paul, for your very nice presentation. You can have a seat there, as other presenters will join you soon. So, allow me to call the second presenter, who is called Mr. Jean-Claude Uwimana. Jean-Claude Uwimana, he's a senior nurse, perioperative nurse working at Kibogora Hospital, and he's going to present the study titled Evaluation of Procedure, Understanding and Satisfaction with Informed Consent among Adult Elective Surgery Patients at Kibogora District Hospital. You are welcome, Mr. Jean-Claude. You have 5 minutes for this presentation. Thank you.
Good afternoon. I'm Jean-Claude Uwimana, a perioperative nurse at Kibogora District Hospital. I'm going to share with you the findings of my study on evaluation of a procedure, understanding and satisfaction with informed consent among adult elective surgery patients at Kibogora District Hospital. As we know, the surgical informed consent entails what a surgical team communicate to their patients about the proposed procedure. It is also a key element toward reducing medical legal litigations. In Rwanda, little is available regarding the practice of surgical informed consent. The main purpose of this study was to evaluate the procedure, understanding and satisfaction with informed consent among adult elective surgery patients at Kibogora District Hospital. Globally, 313 million procedures are undertaken worldwide each year. The World Health Organization recommends the patients consent before they undergo surgery. The history of informed consent is dating back from over the last 130 years, and the idea of standard of care was replaced by a well-informed patient since the trial of Nuremberg on December 19, 1946, and the practice of surgical informed consent has emerged from that time. In 2019, the Canadian Medical Protective Association reported that over 65% of medical legal actions involving informed consent were surgical. About the method, during this study, we used the quantitative approach, and also we used descriptive cross-sectional design. The simple random sampling strategy was used to find 133 free, awake, and stable adult patients undergone any elective major surgery. After getting URIRB ethical clearance and approval from Kyogora District Hospital Research Committee, a structured questionnaire was used to collect data. Data collected were analyzed using SPSS software version 26. As a result, in all of 133 respondents, 59.4% were male, 51.1% finished the primary school, and only 8% had a previous history of surgery. 59.4% of all participants were in inadequate information class. The level of understanding with the surgical informed consent information was low in 96.2%. The level of satisfaction with the surgical informed consent information and the process was low in 75.2%. As I'm rushing with time, I want to go to conclusion. There is a poor process of surgical informed consent. There is also a low level of understanding and a low level of satisfaction. Low level of understanding and satisfaction was found to be associated with gender and the history of a previous surgery. Recommendations to Kyogora to develop a protocol on the amount of information to be disclosed to patients before surgery. To healthcare providers also should provide adequate information regarding the proposed procedure. For the researchers, I would recommend them to conduct a large-scale survey to find out the status of surgical informed consent in a Rwandan health facility. Thank you.
Thank you, Jean-Claude Uwimana, for trying to respect our time. Then let me go to the next presenter, who is Dr. Eugene Uwizeyimana. Dr. Eugene Uwizeyimana, he's a senior resident orthopedics, and he's going to present the study titled Assessment of Preventable Causes and Predictors of Independent Ambulation for Cerebral Palsy in Rwanda. This was a retrospective study done by him. Let's hear from Dr. Eugene Uwizeyimana. You have 5 minutes for your presentation. Thank you.
Thank you. As he has said, I'm Dr. Eugene Uwizeyimana, so I'm going to present on the assessment of preventable and the predictors of independent ambulation for cerebral palsy in Rwanda. So let's recognize my supervisors, Prof. John Bimana and Dr. Arben Zaisenga from the support from this work. So cerebral palsy is a group of disorders of the development of the movement and the posture. So this is causing limited activity, and this is to progressive immature brain injury. So cerebral palsy worldwide is the common cause of motor disability in the children, and as a difference is totally different when you compare the high-income countries and the low middle-income countries. So as you see on slide, the prevalence is 2.9 to 3.6 per 1,000 children in Uganda and Egypt, respectively. So where in high-income countries like in US and Europe and Australia is trending between 1.8 to 2.3 per 1,000 children live birth. So this condition is really a burden to orthopedic practice worldwide, including in Rwanda. And unfortunately, our research, there is no single research done on cerebral palsy in Rwanda. So our objectives is to identify different preventable causes and to determine the mode of treatment given in specialized hospital, RIMA, and also to identify the factors predicting the independent ambulation for our patient. So this study was conducted in specialized hospital, RIMA. It covers the whole country, and this hospital located in 5 kilometers from here, and this is a retrospective study. We included clinically diagnosed cerebral patient aged between 2 to 18 years, and which has flowed between January 2016 to June 2020. So the data collection we used data designed questionnaire, and we calculated the sample size according to Henry-Fisher formula, where our sample size is around 385 patients. So analysis was used SPSS version 24, and univariate analysis was used to determine preventable causes, and T-square and logistic regression used to identify the predictors. So our study was approved by CMH and the ERB and CCO RIMA, and to results, 395 patients were recruited, where the male, they are 53%. There is, it's equally affected when you consider the gender, and the median age is 4 years. So according to motor type, the spastic motor type is the most common, and for the motor severity, the growth motor function classification system level 4 is the most common. So the risk factors found is the fetal distress, low birth weight, congenital malformation, and prematurity is low if we compare with the high countries. So the duration is sitting before 2 years. So when the child is able to sit before 2 years, it is a good prognostic to independent ambulation, and motor severity and topographic distribution like quadriplegia, hemiplegia is significant to predict the ambulation. So if the child has no visual impairment or epilepsy, it is also a good prognostic to predict the ambulation. So the mode of treatment done at CCO RIMA, it's gait training about 55%, and about the surgeries, they are tendon lengthening and tenotomy. So if we see they are not frequently used as the treatment. So for the discussion, our patient relate to consult, where we find more than 50% are above 4 years. So this is consistent with other studies in low middle income countries, but different to high income countries, where in high income countries they are able to make a diagnosis between 12 to 24 months, and in Australia we found 21% have the diagnosis even before 6 months. So in our study, we found that mothers didn't report disease during pregnancy, and this is different to other studies in high-income countries where they showed chronic condition, especially when it comes during pregnancy. It is associated factor to have children with cerebral palsy. And the common causes we found in term babies, which is different to high-income countries, where the preterm babies, the prematurity is high. So this can be explained by our equipment, the NICU, where our preterm babies, most of the time, they die even before reaching the age of 2 years. So, as we have seen different type of surgery, it is not done here, but in high-income countries, there are many type of surgeries done, including the osteotomies, the correction of the deformity like scoliosis, but it is different to our setting. So, as a conclusion, the majority of children in our study, they are term babies, and many risk factors we find they are preventable. So to establish the preventive and management strategies are highly needed in developing countries. And for the recommendation, so we recommend so doctors who are in contact with those high-risk patients or maternal to assess and treat all chronic condition to mothers, and to adopt the international guideline. So this is published by Novak, which have 3 elements that we can use to detect the CP in lesser than 6 months. So we recommend also to Minister of Health to facilitate the access to medical and surgical care to CP patient, and the advocacy it is needed about the management and the education, and also to initialize the National Cerebral Palsy Register to know the trend of the disease. So for future researchers, we recommend to conduct nationwide population-based study. So this will help to know really the prevalence of cerebral palsy in Rwanda. So thank you for your kind attention. This is.
Thank you, Dr. Eugene, for your very nice presentation. Allow me to call the last presenter, who is Dr. Jean de Dieu Nsanzimana. He's a senior resident in general surgery, and he's going to present to us the study titled Epidemiological Profile and Factors Influencing Short-Term Postoperative Outcomes of thoracic surgical condition in tertiary hospitals in Rwanda. Dr. Jean de Dieu, you are most welcome. You have 5 minutes for your presentation. Thank you.
Thank you for this opportunity to present. My name is Nsanzimana Jean de Dieu, a senior resident in general surgery. This work has been supervised by Professor Faustin, Professor Martin, and Dr. Musoni Maurice. So the topic is epidemiological profile and factors influencing the short-term post-operative outcome of thoracic surgical conditions treated at tertiary hospitals in Rwanda. So general thoracic surgery is now increasingly becoming a specialty of much interest. However, there are many areas of gaps, including unmet patient needs, insufficient thoracic surgical workforce, equipment, resources specific for thoracic surgeries. In addition to that, thoracic surgery has been absent for a long time in the general surgery curriculum of the University of Rwanda, and until now, no thoracic surgical training program available. So those gaps make graduating general surgeon less exposed to disease amenable to thoracic surgery and leaving behind research in that area. So in Rwanda, very few studies regarding thoracic surgical diseases appear to be not well grounded. And among them, no study till now, to the best of our knowledge, managed to address the factors of outcome. After this combination, it is important to understand the burden, clinical profile, specific challenges, and the factors affecting the outcomes associated with thoracic surgical condition in our settings. And this will help to inform the curriculum development, policies, and the patient-specific guidelines. So this was a two-part. It was the retrospective and the prospective observational study done in CHUIB and King Faisal Hospital. And all patients with thoracic surgeries has been included, and we used a non-probability convenience sampling. And also the outcome of interest, the primary outcome was a 30 days postoperative mortality, and the secondary outcome was morbidity. And we have used a multivariate analysis to see the correlation between the variables and the factors associated with outcomes. So in total, 142 patients has been followed, and they were predominantly males, around 42 years, and the patients were predominantly operated at King Faisal Hospital, and 74% of the patients at least attended secondary school and were in low socioeconomic category at 81%. Ampihematorosis was the most common pathology, and followed by the lung tumors, mediastinal tumors, bronchiectasis, and esophageal carcinoma, and other pathology found were foreign body esophageal stricture. And the most common performed operation was lung decortication, lobectomy, and also other operation were mediastinal mass resection, pneumonectomy, and esophagectomies. And the mortality and the morbidity were 58 and 11.9% respectively, and the most common complication has been found to be an increased hospital stay more than 7 days, and pneumonia and SSI. And the other complications found were organ failure, atelectasis, and reoperation. So for multivariate analysis, it has been found that operative duration more than 3 hours, SA classification more than 3, and type of surgeon were the most predictors of outcome. So we have been found the same clinical, the same epidemiological profile with the other areas like Sudan, Nigeria, and Zimbabwe, and the ampihematorosis and the other surgeries has been the same for the other areas like Sudan, in Nigeria, and Pakistan. And also, the morbidity was comparable according to the other areas, but they differ in mortality, where we have been found you have an increased mortality rate if you compare to the other centers, but which is in high income categories. And operative duration, SA class are similar in France, Brazil, and the United States. And also the type of surgeon to mean general surgeon and cardiothoracic was also the factor of outcome. There is 2 studies done in the US where showed that cardiothoracic surgeon, they have a better outcome compared to the general surgeon. But this relationship need much attention because they have showed that this is closely related to the surgical volume, not necessarily the specialty. So this is needing also other future studies. So to conclude, thoracic surgical conditions are common in males, and ampihematorosis was the most common pathology, followed by lung and mediastinal tumors, and the most common performed surgeries were pulmonary decortication, lobectomy, and thoracic mass biopsy. The mortality in our patient is comparable with other population. However, the mortality is high in our patient and associated with long operative duration, high SA class, and type of surgeon. So we recommend University of Rwanda, MOH hospitals, the following University of Rwanda with the Ministry of Health are recommended to have this advocacy to start postgraduate or fellowship training in this area of surgery, or to support some of newly graduated general surgeon the way to access this training. An assessment of reason of delay of consultation of patient with thoracic operations. This is because also a duration of symptoms was associated with poor outcome on bivariate analysis. Training and regular mentorship of these hospitals physician about early recognition, initial management, and timely referral of patients with thoracic surgical pathology, especially infectious disease and trauma. So we have also established the risk assessment protocol and the guidelines on perioperative management of thoracic surgical condition to anticipate the outcome. And you have also to conduct a country-wide studies to work on the remaining subject of this current study. Thank you very much.
Thank you. As all presenters from the session number 3, or the first general paper and the second general papers, please, you are welcome to move forward. And if even to you, Mr. Michael Bahrami, if you, because there was no question asked to you, if you like, you can move forward. And anyone who have a question, it's the time, and we have 10 minutes. And I'll start with the question asked to Mrs. Esperance on YouTube. Mr. Jean was asking about, I would like to ask the presenter, Madame Esperance, what are those patient factors that affect patient outcome postoperatively? And another question was asked to to Dr. Isai. Does the infrastructure as priorities, number 1, comparing to train expert in cancer treatment, available technology and medication, just to have its reaction? Thank you.
Thank you for the question. By
Thank you. Good presentations. Mine goes to Jean-Paul. So I'm happy when surgeons start speaking health economics and money. And it means that we are caring about the socio-economic health of our patients. So one is for the audience and for us who are not so conversant with the terms and these new kind of topics. Can you please elaborate a little bit and explain what you call catastrophic health expenditure, the definition? And further to that, would you recommend that we include in surgical training a module on health economics?
Thank you very much for good topics. I wish we had more time. The discussions are good. So the one who discussed about surgical notes, in your findings, do you find any person drawing notes? In a notes you write, you draw, because we know that when a person draws during notes in writing, that's a master of the anatomy. Did you find such? Then on the informed consent, if a person said, is informed consent informed? You need to discuss that when you found, yes, you told us about low levels, but they sign. So what does that mean in terms of litigation? I think for the person on a CP treatment, somebody, the presenter said there is no treatment for spine deformity. That's not true, but if it is not true, I would take you further and get to tell us about the cost of being deformity correction. So for those are many questions. For the Dr. Shinjiro's topic, that will need another discussion because his presentation is novel. He's bringing new ideas as to first the diagnosis and an understanding of child malformation. So that the drawings that you put, okay, so there is an MRI and then the schematics. I think if you can do us a favor and show them, for those that are interested in knowing what Chiari is, those drawings they will carry more. So maybe you should have displayed them more so that people will understand the Chiari malformation. Thank you very much.
All right, there was one, let me come to you. I think they are becoming
Thank you. My question goes to Dr. Eugene, who presented about the cerebral palsy. Just I was want to know if in your recommendation you are planning to present your results or to guide and help us and others GPs who are just caring pregnant mothers to prevent those consequences of cerebral palsies, and also to in the curriculum to increase, if I can say, the hours medical students are spending in guide and help so that they get awareness of this catastrophic, I can say, of cerebral palsy as mothers, and also to include also community health workers about these consequences if the antenatal care is not followed well. Thank you.
Thank you very much. The question is coming from online and addressed to SP. It's saying it seems that patients under surgery for advanced stage cancer are from low middle income countries comparing to those from high income countries. With your experience, how does patient pathway from health center to a specialized hospital affect the early detection of cancer in low middle income countries or in Rwanda? It's a question from online. Thank you.
Thank you. You can now start replying kindly. Thank you.
Thank you for the questions. The first question was asking me by Joe, what are the factors, patient factors looked on in this study? Of course, surgical cancer and patient factors looked on during this study was age, sex, smoking, body mass index, immune system like HIV status, and by there it was raised up that identified patient components related to this factor is opening a room for further studies. For example, where we think that males are likely to have more cancers and mortality rate compared to the females, respectively, 2 further higher than male than females. 50.8% versus 7% of female per 100 people are having those type of cancer. Those factors are more likely to be detailed or started on in further studies. The second one was asking, according to experience, how patient pathway affect patients cancer surgery outcome in lower income countries or middle income countries where we are. We know, all of us, that the early detection of any type of cancer will result to early getting treatment or including surgery. In lower income countries, settings are limited to investigations like imagery, pathology, and even those who have been diagnosed or treated at that stage from 3 to 4, after getting treatment, many of them are on the stage of metastasis, and the palliation is still on a lower. The palliation care system is not well structured from above to the higher tertiary hospital. Thank you.
Thank you. As you are still giving answers to the questions, I would like to remind everyone who didn't register to kindly go on the back where there is the printer and meet Jean de Dieu so that you can register yourself, or if you have a mission paper that need to be signed, you can move forward and go discuss and have your paper signed to Mr. Jean de Dieu. He's at the printer. Thank you.
Maybe I can give some comment on the question asked to Esperance about how the pathway affects the outcome. Most of in low income countries, normally our patient in low income countries presents red at red stage, and this is due to ignorance. They don't know if the symptoms and signs of the disease, and also the ignorance on the side of treating health professionals, because that way of passing from the health center, district hospitals, you see patient, you don't recognize the symptoms, you give treatment, you send him home, and he come back 2, 3, 4 times, and at that time of recognizing the disease, it's at that stage. So this ignorance on both sides and making it to come late at this stage. So on my question, I think it was about the comparing infrastructure versus human resource. Both are necessary, and in this study, they are not only recommending to increase the infrastructures, they are also talking about human resource, and those facilities, meaning infrastructures and human resource, are combined. And in the management of cancers, the cancers we talked about, or even all cancers, common cancers, all the two are important, are very important, from the diagnosis to the diagnosis, to the treatment, to the post-operative care, even the presence of oncologists and trained nurses for post-operative management. So all both are important.
Thank you. Thank you for the question. The question from Prof. Musi, it's about the treatment of cerebral palsy, especially for spine. So in our study, we found that the study that was conducted at a specialized hospital, Ririma. So we found that among the surgeries done there, it's tendon lengthening and tendon release and tendon transfer. So there is no spine surgery done there. So what I think is about the specialized personnel in spine surgery, and another concern is about the cost of the malformation of the spine. Those children got scoliosis, and we know that it is very expensive. And another we can think it's about the outcome from the surgery. So in our study we found that surgeries, they are not frequently used as mode of the treatment when we compare to other high-income countries. So for the second question from Dr. Hale, so about the recommendation. So this is a disease or a group of syndrome, most of the time affecting the motor disability, and so it's good to recommend, or to recommend to know really the knowledge to know about the pathophysiology of the disease, so we can make advertisement if a child have like delayed any developmental milestones, even to recommend it to community health workers to know if a child has this delayed developmental milestones, to consult the specialized hospital, because it is shown if this condition it is detected early, the management will help, because the brain of the child, they are still having that capacity to adapt to physical exercise. So it is good to recommend to community health workers, to medical students, and to other people who are in contact of this patient. Thank you.
Yes, there was a question.
Thank you. Happy to respond to good questions, questioned by Prof. Austin, so that we clarify some of the important items we've been using. So starting with if we may recommend the module of health economics. So the answer is straightforward, yes, because we have to understand how the patients, they earn money, how they expend them, and how it allows in their daily activities, how it allows to shape their capacity of payment. So now, with understanding of how much they are gaining and how much they spend on their daily life and how much they spend on the health, so it will allow us to understand exactly how we may know the cost of interventions we are giving to those population. Then with that, we may know exactly how to protect them from not paying too much of out-of-pocket money, which may impede their daily activities and daily life. So we really recommend that this model may take place in our studies. So another question was to talk about the catastrophic expenditure. What is it? So we would be saying that when there is out-of-pocket payments for the health care, which is exceeding the specified threshold of the house incomes or just households' capacity to pay, which is beyond a designed threshold, because if the capacity to pay of that population is beyond that threshold, then they may enter the catastrophic expenditure. So what we mean here is that there are some of the thresholds which has been used in different regions, but the commonly used in literature is the 10% threshold in literature, and WHO is using 40%. So now, when you are the population has to pay, or just the households or just the individual has to pay beyond that threshold. Either you may take 10% or you may take 40% as stated by WHO. Then if you go beyond one of that threshold and the out-of-pocket money you've used is beyond that threshold, then definitely that patient or that household is falling in the catastrophic expenditure, and that means that the patient is falling in the poverty. Then we have to be against that so that we allow the patient to have their daily life and living their daily life without just paying the out-of-pocket money which make them to fall in poverty. So now, lastly but not least, was also to clarify about what we call micro-costing studies. So micro-costing is just a bottom-up analysis. So it's a costing study where you state the cost of each item which composing an intervention. Then you state this part is costing this amount. Then you sum up all the charges around the intervention. Then you know exactly what would be the cost for intervention. Thank you, Prof, for these questions. I got the opportunity to clarify these things. Thank you.
Thank you. I was asked if the while evaluating the surgical notes, there were some drawings by Professor Hosi, the standard. So we found it is not like systematic, but it was found used most in cases involving gallbladder surgery. I mean cholecystectomy, where surgeons and residents, they make sketches or drawings, illustrations, especially depicting what is called the carrot triangle. And I think that was the cause cholecystectomy scored high. It scored above 12, which is considered as high scoring. Thank you.
All right. Yes, consent. There was a question asked about consent.
Thank you. I would like to ask Professor Mosi to please come again with the asked question. Thank you.
The question is, we talk about informed consent by just giving people to sign a consent, and they sign it. So the question I asked you, is it actually informed consent? Sorry? Or people signing to have surgery? So what were our findings? What were why is it low? Why did it score low? What were these people's complaints? Why are they not? Why are they saying they are not informed? Is it the language? Is it the way the consent is? What is it? That's why I said, is informed consent informed consent?
Thank you.
Now I'm going to niba nshaka kubagwa because I have, for example, with the appendicitis, bakubwira ko ukeneye kubagwa, and for you just sign to have surgery. You don't know the complications. You just want this thing to be done. And then I asked, how is it related to litigation? When there is, if you have cases of litigation, how many were related to informed consent being not informed?
Thank you. Normally, a consent form should not be done for formal regulations. It should be a good opportunity for a patient to get enough explanation on what is going to be done on him, and then he receives a time to take decision. It is also a good opportunity for the patients to study, because if we know that the procedure which is going to be performed on the patient, there is a risk of infection, we need also to explain him or her that there is a such risk of infection, and then the patient may decide accordingly. And this is where the claims come from. Once he has been not explained the risk or the benefits of having surgery, or the alternatives in case the procedure is not performed. And once he has not been given as such explanations, and if something goes wrong, that's where the claims come. So it is better to take enough time while taking the informed consent to teach and explain to the patient, and let him or her a time to decide accordingly. Thank you.
Thank you. We are going to continue other questions and answers during our coffee break, which will happen after the closing remark. But there is a burning question regarding community engagement, so let us hear from him.
Thank you. Normally when you're doing research, you have to have specific objectives you want to achieve with your research. How do one balance with those specific objectives and the input from the community? Because you said when you're doing a community engagement research, you have not only to have your objective, but also to get the input from the community. So how do you balance between the two?
Thank you. That's a very good question. Normally, the challenge is you have your own research objectives, but what if the input from the community does not match your objectives? Good question. I think it's all about transparency. We also have this issue in the UK. It's important at the start, when you go to a community, that you are transparent with them about aspects of your research that they can influence and aspects of the research that they can't influence. Let me give you an example. Normally, when we use survey tools, for example, a survey tool after operations, these are usually validated questionnaires. And these validated tools cannot be changed by patients because they've been validated. So how then can you actually get patient input and use tools that can't be changed? So one option that I tell researchers is to show the different tools, translated of course, to the patients. For example, there's a tool for general well-being called the SF36, which is 36 questions that asks patients how they would rate their health. But there's another tool that's also validated called SF12. It's shorter. It's shorter, but it doesn't give you as much information. So you can present these two tools to the community, ask them what do they think is a better tool to use, but telling them that they can't change the tool itself because that's validated. So at the end of the day, it's about telling communities, this is what you can influence, but this part you can't really change because that's part of the protocol which we follow as scientists, as scientist physicians. So it's just about transparency. I hope I answered your question. But thank you for your question.
Thank you very much. A round of applause to all of you. As they go back to their seats, we're going to welcome a wrap-up session. We're going to have a wrap-up session by Dr. Sosten. And after that, we're going to have a closing remark by our Dean, who will be welcomed by Prof. Faustin Nirenganya. And after that, we'll have the coffee break, plus the networking session with the presentation by having the posters presentation. So we'll have our coffee while touring around the posters so that we see the work done by others who were not able to present here with us. So Dr. Sosten Habumuremyi is hold a PhD in biology from Leipzig in Germany. He has extensive experience in teaching and research management in learning institution, and he's the hub manager of Rwanda Global Surgery Research Hub. Thank you very much.
Thank you, MC. Good afternoon, all. For the wrap-up, we have tried to summarize the recommendations that you have given. So we had in total like 76 slides. So you can understand that it was not easy to make a summary, but we promise that at the end we'll make throughout edit and then we'll publish it. But for the moment we have selected 10 key recommendations for call to action or practice change. So the first recommendation is to promote evidence-based surgical practice. The second recommendation is to grow global and multidisciplinary networking and collaborations. The third, translating research output into policies for impactful surgical care standards. Fourth, transforming Global Surgery Research Hub into the Center of Excellence in the next 5 years. Fifth, mentoring students and hospital staff. 6, keeping up inclusive research. 7, engaging community in surgery research. 8, welcoming new projects and clinical trials. 9, commending alignment of surgical research to good clinical practice. 10th, but not the least, upscaling and equitably providing timely surgical care to improve surgical outcomes. So thank you, MC. I think that's...
This was the best presentation from the morning. Two minutes and everything was well concluded and summarized. So I don't think we have any other thing to add. Kindly, Prof. Faustin, you are welcome to welcome our Dean as he gives us his closing remarks.
Thank you, Grace. Thank you, everyone. This has been a very long day, and we are smoothly reaching the end. But before I call the Dean to come and close for us, have to summarize a little bit for him because he joined a little bit later. He had another conflicting agenda and another high-level responsibility that he had to attend. But he had promised that he will be coming in the afternoon, and he did so. Thank you for coming, Mr. Dean. So we started in the morning with the opening remarks given by Madam Principal, and we went further by giving an overview of what we do as a hub. And I will not be briefing him about the hub because he knows what it's all about. And we followed by a number of sessions, which was quite very interesting, and I was amazed and impressed by what people are hiding there in the cupboards. So we really have a very interesting research output here that we should be proud of. So thank you all the researchers and the presenters for making this day as good as it has been. So without taking further of your time, let me introduce my Dean. So I know him for 30 years now because we have been together in a secondary school. So you see how long it is. And now, Prof. Jean-Claude Byiringiro is an associate professor of surgery and the current dean of the School of Medicine and Pharmacy. He formerly been a head of division and of research and education, the University Teaching Hospital of Kigali, and the head of the emergency department there. He has been chair of Rwanda Medical and Council, and he is a well-renowned researcher, and he attracts a lot of grants to our school, and he has been champion of everything we know now in trauma and injury in this domain of global surgery and research. So, Dean Byiringiro, you are welcome.
Thank you very much, Professor Nirenganya, for introducing me and actually reminding me that we know each other for the last 30 years. I think we have spent much time together than we lived. So, good evening, ladies and gentlemen. Mr. President of Rwanda Surgical Society, or visitors from abroad, the head of Department of Surgery, fellow colleagues, surgeons, trainees, and our very lovely colleagues, nurses, and people from other sectors. I see people from so different areas. I don't see everybody, but it's really a tremendous opportunity to be sitting here today to discuss other matters. It's a privilege and an honor to me today to be standing here speaking about the topics I really enjoy the most. I will speak on my own behalf as a dean, but also as a surgeon, but also I will speak on behalf of the University of Rwanda. It's important to stand here today looking at surgeons who are busy in their practice, nurses who are busy in their practice, and probably others that have been presenting today that are not necessarily surgeons or nurses, about this noble profession that we do. You know, this is a joke, but it's probably happening. People will see us as very busy people working most often in very narrow openings. I will think of my colleague here, ENT. Sorry for referring to you. You are probably the first person who is working in very narrow openings. But there are others, those working in the urological openings. You probably are working in those very narrow openings. Sometimes we are lost in our very narrow opening. We used to say that great surgeons use big incisions. Now, this is outdated. We are going narrow and minimal and minimal. Now, we need to come out of our narrow openings to shine out, to take a step back and observe what we do. and see broadly now, not in operating room, not in our operating site. See, what are the outcomes of what we do? It has been a very great opportunity today to sit back and see what we do, what are the outcomes, can we change anything, because we are supported by evidence. We probably must decide, especially for our young colleagues here, of which kinds of surgeons we want to be. Is that a routine surgeon who just come and treats the patient they see, and that's all? Your day may be impacting on 15, 20, 30, 50, or even more, but will be your action will be having impact on a very few number of people. So we need to come out and combine surgery and science in such a way of synergy that improves the survival and outcome of the surgeries that we perform. And that is going to impact the health of our population. I was very impressed by the quality of the papers that were presented today. Even though I missed the morning sessions, I had a chance to scan quickly through the book of abstracts, and I was really impressed. I could see some social determinants of ill health, which are very relevant and which is a very topic of today. We could see some evidence and new knowledge coming out. Some implementation science coming out. Community engagement, which is another very key element. Combining all of this together, I think we learned a lot. And this is probably going to impact our practice. And after impacting our own practice, it's probably going to improve the lives of our populations. So it is really such a great opportunity to have people here gathering, sharing, evaluating the surgical profession, the surgical practice, by not only surgeons, but also with other professionals that are working closely with us. It is my sincere hope that our young colleagues who are here, young surgeons, residents, fellows, medical students, if any are here, that we must choose this noble career of not only performing surgery and not treating a patient who is tapping at your door, but building a work that is impacting the population, not only just a patient who is stepping at your door. So it's my sincere hope that we find more scientists among you, especially young generation. I want to thank, as I close this speech, to thank the Global Surgery Research Hub for their tremendous work and for thinking of gathering us together to discuss on what everybody does. I want also to extend our warm thanks to the funder, the NIHR, which probably has funded much of the work done by the Global Surgery Research Hub, and through the other UK and other universities working with us on implementing such big changes in the surgical career. and not just only focusing on our local concerns, but also learning from the global experience, because we are now in a very nicely connected world. I welcome so much the recommendations that came out from this meeting, which are very nice to see. And I'm happy to support and facilitate as much as we can through the leadership of the university, looking at the evidence base, engaging in global and multidisciplinary surgery, translating research into practice, reaching out to the community, transforming the research hub into a center of excellence. What a nice idea. Engaging more in trials and looking at a good clinical practice, and others that you have listed as important recommendations. So we are very much excited and happy to keep working with you to increase interest in surgical research and in surgical science. I will also call upon the young generation again to see the other opportunities of upgrading their skills. Why don't you take other studies, especially research training, through the university? Now that you are joining the university, there are plenty of opportunities for even working on a PhD in surgical sciences. Why not? Because it's the only way we can advance together science and develop skills that are necessary to advance our practice. So I don't want to take much of your time. I thank everybody who is here for your time spent on exchanging on all of these very relevant topics. And I wish you a very nice evening. Have a very good coffee moment. Thank you so much.
Thank you once again, Prof. Byiringiro, for the closing remarks. For reminding us that we should all be vessels of targeting a center of excellence in these 5 years. I hope we are grateful for more than 100 attendants, online and physical, who were all very engaging and asking questions. So we thank you very much for your time and commitment. So we hope the next second hub will be more engaging, more than 200 people attending, and having more amazing researchers as the one presented today. Personally, I think orthopedics were lagging behind. I'm committed and are going to work with our team to improve with the clinical trials. Thank you very much. So we're going to have our coffee as we wind up, and we kindly welcome everyone or anyone who has a poster to take the coffee and come quickly to stand on your poster, so that in case there is anyone interested, you never know whom we are meeting. You might be meeting someone who's sponsoring you to go back to attend the Bethune Roundtable with the research. So please come, stand on your topic, and if there is anyone interested to ask you questions, so you can be available to market yourself. So thank you very much. It was lovely to be invasive and non-invasive with the hosting. Anyone whom I pushed to be quick, my apologies, but we needed to finish up quickly. Thank you very much. Hello? Anyone who needs a CPD?